O'zbekiston Respublikasi Prezidenti rahbarligida mamlakatimiz sog'liqni saqlash tizimida olib borilayotgan islohotlar tufayli bugun tibbiyotimiz taraqqiyotini muhim bosqichlarini boshdan kechiryapmiz. Bir necha statistik raqamlarni keltirmoqchiman. 2016-yilda tibbiyotga byudjetdan ajratilgan yillik mablag' hajmi 5 trillion so'mni tashkil etgan bo'lsa, bugungi kunga kelib ushbu raqam 42 trillion so'mga yetdi. Ixtisoslashtirilgan tibbiy markazlar soni 2016-yilda atigi 10 ta bo'lib, 2025-yilda 25 taga, hududiy filiallar soni esa 130 tadan 300 taga yetkazildi. 2024-yilda birinchi marta yurtimizda 5 ta va bu yil bitta ixtisoslashtirilgan ilmiy amaliy tibbiyot markazlari xalqaro sifat sertifikatlarini joriy etgani munosabati bilan xalqaro akkreditatsiyadan o'tdi. Birgina urologiya sohasini olsak, so'nggi 2 yil ichida davlat tomonidan respublika ixtisoslashtirilgan urologiya ilmiy amaliy markazi va uning filiallariga 13,8 million AQSh dollari mablag' ajratildi. Shu jumladan davlat tibbiyot muassasalarida ilk bor robot uskuna o'rnatildi va ishga tushirildi. Yana bir muhim raqamlar. 2017-yilda 3454 ta bo'lgan xususiy shifoxonalar soni bugungi kunga kelib qariyb 3 baravarga, ya'ni 9500 tadan oshdi. Ular tarkibida kardioxirurgiya, neyroxirurgiya, torakal xirurgiya, intervension kardiologiya, onkologiya, onkoxirurgiya va urologiya yo'nalishlariga ixtisoslashgan muassasalar ham mavjud. Bugun xususiy sektorda faoliyat olib borayotgan shifokorlarning 17 ming nafaridan ziyoda va hamshiralarning esa 26 mingdan ko'proqlari hammasi xususiy tibbiyotda xizmat qilyapti. Bu raqamlar juda biz uchun muhim. Va bu xususiy tibbiyotning lokomotivlari Akfa Medline Universiteti klinikasi barcha xalqaro sifat standartlarini javob berib, 2020 va 2023 yillarda 2 marotaba CAEC xalqaro sertifikat kompaniyasini akkreditatsiyasidan o'tib, O'zbekistondagi yagona tibbiyotning oltin sifat belgisi egasiga aylandi. Bugungi kunda respublika ixtisoslashtirilgan urologiya ilmiy amaliy tibbiyot markazi ham, Akfa Medline xususiy klinikasi ham eng zamonaviy diagnostika va davolash asbob uskunalariga yuqori malakali mutaxassislarga ega bo'lib, Markaziy Osiyo mintaqasida yetakchi o'rinda ketmoqda. Ushbu tibbiyot muassasalari mamlakatimiz aholisiga eng zamonaviy texnologiyalar asosida deyarli barcha turdagi urologik tibbiy xizmatni ko'rsatib kelmoqda. Hurmatli anjumanimiz ishtirokchilari, hammamizga ma'lumki, tibbiy xizmat bilan bir qatorda tibbiyot uchun kadrlar tayyorlash yangi bosqichga o'tdi O'zbekistonda. Davlat tibbiy oliygohlari qatori xususiy tibbiy ta'lim muassasalari ham ushbu jarayonlarga o'z hissasini qo'shmoqda. Bunga xalqaro standartlarga mos bo'lgan ta'lim dasturlarini faol joriy etgan hamda innovatsion o'qitish uslublarini qo'llagan, darslar to'liq ingliz tilida olib boriladigan tibbiyot fakultetiga ega yurtimizdagi ilk xususiy universitet bo'lgan Markaziy Osiyo universitetini misol qilib keltirish mumkin. Ushbu oliy ta'lim muassasalari dunyoga mashhur Cleveland Clinic bilan birgalikda Toshkentda tibbiyot kampusini tashkil qilmoqda. Bu esa tibbiy ta'lim, amaliyot, klinik tadqiqotlar va sog'liqni saqlash sohasida xalqaro loyihalarda ishtirok etish uchun noyob imkoniyat hisoblanadi. Ushbu ulkan loyiha 30 dan ortiq tibbiyot yo'nalishlarini qamrab oluvchi tibbiyot shaharchasini qurishni maqsad qilib olgan. Hurmatli tadbirimiz ishtirokchilari, O'zbekiston Respublikasi Prezidenti boshchiligida tibbiyot sohasidagi islohotlar kunbay sodir bo'layotganini amaliy isbotlarini har kuni ko'rib turibmiz. Jumladan, bugungi Markaziy Osiyo endokirurglarining 1-kongressining o'tkazilishi ham ana shu isbotlardan biridir. Respublika ixtisoslashtirilgan urologiya ilmiy amaliy tibbiyot markazi, Markaziy Osiyo universiteti, Akfa Medline universitetlar klinikasi hamda O'zbekiston urologlar jamiyati bilan birgalikda o'tkazilayotgan anjuman mamlakatimizda davlat, xususiy sektor va nodavlat tashkilotlarining hamkorligining zo'r ko'rinishi deb hisoblanadi. Ushbu kongressga dunyoning ko'pgina mamlakatlaridan yetakchi olimlar taklif etilgan. Bular Buyuk Britaniya, Italiya, Amerika Qo'shma Shtatlari, Daniya, Fransiya, Ispaniya, Turkiya, Hindiston, Singapur, Rossiya Federatsiyasi, Gruziya va Ozarbayjon va ko'pgina boshqa davlatlardir. Anjuman xalqaro ilmiy va amaliy aloqalarni mustahkamlashga qaratilgan bo'lib, zamonaviy urologiyada diagnostika hamda davolash usullari borasida yetakchi olimlar bilan tajriba almashish va zamonaviy yuqori texnologik jarrohlik usullari bilan tanishish imkoniyatini beradi. Markaziy Osiyo Endourologiyaning birinchi kongressini ochiq deb e'lon qilish bilan birga barcha chet ellik mehmonlarimizga vatanimiz O'zbekistonga xush kelibsiz deyman. Va so'zimning yakunida O'zbekiston Respublikasi Sog'liqni saqlash vaziri Asilbek Anvarovich Xudoyarov nomlaridan, butun vazirlik xodimlari nomidan barchangizga bu kongressni samarali o'tishini tilab qolaman. Sog' bo'linglar, salomat bo'linglar. Rahmat.
Rahmat hurmatli Elmira Ekinna, tashrifingiz va tabrikingiz uchun minnatdorchilik bildiramiz. Biz esa davom etamiz. Ijozatingiz ila navbatdagi tabrik uchun sahnamizga yana bir faxriy mehmonimizni taklif etsak. O'zbekiston urologiya sohasining peshqadami, yetuk olim va urologiya sohasida ilmiy tadqiqotlar rivojiga hissa qo'shayotgan inson, O'zbekiston urologlar ilmiy jamiyati prezidenti professor Farhod Akilov. Assalomu alaykum.
Assalomu alaykum, hurmatli hamkasblar, do'stlar. Bugungi birinchi Markaziy Osiyo Endourologlar kongressini ishtirokchilari. Здравствуйте, дорогие коллеги, уважаемые друзья, гости нашего Центральноазиатского первого конгресса урологов. Наверное, то, что первый конгресс эндоурологов в Центральной Азии проводится в Узбекистане, в Ташкенте, это не случайно. Сейчас можно вспомнить, что примерно 40 лет назад была выполнена первая эндоскопическая операция в научном центре урологии. И за короткий период мы тогда вышли на цифру выполнения примерно 1000 эндоурологических операций в год. Это была очень большая цифра тогда. И в этом очень большая заслуга нашего учителя и первого директора Центра урологии профессора Арустамова Дмитрия Львовича. Сегодня практически в каждой области, в каждом регионе уже есть эндоурологические отделения, подготовлены специалисты и выполняются сотни и сотни очень сложных высокотехнологичных операций. Но, наверное, вот этот год и июнь месяц у нас был очень богат на события, и эта неделя ознаменовалась еще одним крупным для нас событием, открытием в Центре урологии впервые в Узбекистане и, наверное, в Центральной Азии в государственном учреждении роботической операционной. И уже выполнены первые операции. Для этого тоже была проведена очень большая работа. Были заранее подготовлены специалисты, операционные бригады для того, чтобы после монтажа оборудования буквально с колес начать активную работу. И эта работа постоянно продолжается, поэтому еще раз разрешите приветствовать всех вас сегодняшним конгрессом и пожелать успешной работы. Спасибо.
Rahmat, hurmatli Farhod Atallayevich, o'z minnatdorchiligimizni bildiramiz va fursatdan foydalanib respublikamizning barcha urologlarini ushbu anjuman bilan yana bir bor chin yurakdan muborakbod etamiz va biz davom etamiz. Kelajakka ishonch bilan qarayotgan mintaqadagi yetakchi tibbiyot va ilm-fan markazi, Central Asian University Rector Kamran Gulamov. Assalomu alaykum.
Assalomu alaykum. Hurmatli hamyurtlar, hurmatli mehmonlar. Bugun boshlovchimiz mehmon deb aytilib, biz aslida mezbonmiz, hamkasblarimiz bilan birga. Ruxsat bersanglar, bugun O'zbekistonga 15 ta davlatdan ko'p bo'lgan shu sohani egalari, professionallar tashrif buyurishgan. Shuning uchun qisqacha welcome deymiz. Shu welcome ingliz tilida o'tkazamiz. Rahmat. Dear colleagues and friends, first of all, assalamu alaikum and welcome to our country. Welcome to Uzbekistan. Welcome to the heart of Central Asia. On behalf of our university, I'm pleased to welcome you in the opening of the Central Asian Endourology Congress 2025. It's a great honor for us to host the leading specialists from more than 15 countries, but more importantly, this is not just a meeting of experts, it's a part of much broader and more ambitious process that we are building in Uzbekistan. Today, here, we are laying a new foundation for the development of medicine. For us, Central Asian University is a platform where education, clinical practice, technology, and entrepreneurship comes together. We are building a healthcare ecosystem and launching initiatives that have the potential to transform lives. We strongly believe that the future of medicine lies in prevention, digitalization, and international collaboration. That is why we are investing in clinics, laboratories, IT solutions, and most importantly, in partners like you. Dean of our residency program, Dr. Razim John, and very well-known urologist in Euro-Asia, with his support this year, we've established first and one of the brilliant programs of residency in our university, which will be including urology program. It is 4 years program, and we are keen to prepare the best physicians in each field with coming years. Our mission is to reshape the approach to healthcare in Uzbekistan, to train the next generation of professionals, and to create conditions where Uzbekistan and the entire region will become a hub for global medical knowledge. I want to thank all the organizers and participants of this Congress. Thank you for your contribution to this common cause, and I hope today's ideas and initiatives will serve as a foundation for real change and sustainable development, both in our country and beyond. Thank you very much.
Katta rahmat. Yuqorida hurmatli rektorimiz aytganlaridek, bugungi anjumanga 15 ta davlatdan ziyod davlatlar vakillari ishtirok etishyapti. Bu albatta juda yaxshi ko'rsatkich va buning ifodasi ila keyingi tabrik so'zi uchun sahnamizga Edinburgh Hospital, Cambridge Universiteti klinikasida faoliyat yuritayotgan Yevropa Urologlar Assotsiatsiyasi a'zosi va joriy kongressimizning raisi Dr. Laurian Dragos taklif etamiz. Welcome.
Good morning, everyone. It's a pleasure to be here. This is an event we've been planning and thinking about for a few years now, and it is amazing that actually it takes place. Thanks to everyone attending, thanks to the organizers, the distinguished guests, the Ministry of Health, obviously the Urological Association of Uzbekistan. It is impressive to see how many people are looking towards the future, are looking towards collaborating with Europe, with countries all over the world, and it is really an honor and a privilege for me to be here. I'm here to share some of my experience, but also to learn from you, because I know very well that there is a very, very strong urological and especially endourological expertise in these countries, in your country and in the countries in Central Asia. We thought about organizing this event for many years now, and I'm very grateful to, especially to Dr. Arzinjon Tursunkulov, who has put an amazing time and effort to start this project. I'm looking forward to more development. I'm looking forward to grow this meeting, to arrange it on a yearly basis, and to make it a landmark in endourology and in urology in the Central Asian area. It's a pleasure to have colleagues from so many countries here, and we are already running a bit late, so we should start with the lectures. But again, thank you very much for contributing to this project, for being here at the first session at the first Congress organized. Good. So, can I have something to turn the slides on?
Aziz mehmonlar, mana shunday ko'tarinki kayfiyat ila bugungi anjumanimizning rasmiy ochilishiga yakun yasar ekanmiz. Endi bevosita kongressimizning faoliyatiga bosh o'tamiz. Endi ajoyib mehmonimizni yana bir bor sahnaga taklif etishga majburmiz. Hurmatli kongress ishtirokchilari, endi sizni zamonaviy endourologiyadagi eng ilg'or yo'nalishlardan birini o'z ichiga olgan maxsus ma'ruza kutmoqda. Demak, guldiroz qarsaklaringiz ila endourologiyada lazerlar mavzusidagi taqdimoti bilan so'zni yana bir bor janob Laurian Dragosga beramiz. Marhamat.
So, endourology is obviously not only about lasers, but we have to admit that within the last years, there has been a great focus on lasers, and this is why I think it's a good place to start with. Obviously, we'll go through more topics during the Congress itself. I'm going to try and briefly, go through some of the lasers that we are currently using, but since I come from Cambridge University, for the younger colleagues who are familiar with Harry Potter, you probably recognize this old wizard, and I'm pretty sure you will know what I'm talking about. This is basically, this stone here is the holmium element, and this is how the holmium lasers are built off. But apologies, before I started, I should have invited all the moderators to join the session here. So please, the moderators of the session, if they could join us. Vineet. Professor, please join us. Apologies. Okay. Good. I think we're still missing one person.
Can we invite Chandra Mohan to please come? Are you in the auditorium, Chandra? Please,
Okay.
please come forward.
We will go ahead. Now, talking about the holmium lasers, they have no worries. Thank you very much for joining us. Thank you. Grateful to all of you for being here and moderating this session. We started using holmium lasers a very long time ago, and the machine that you see up here is, one of the old machines. It is quite small, and, one of the things that changed over the years with with holmium lasers, that was, I would say, the first generation, or more or less the first generation, is that they become more powerful. How was that achieved? But it was achieved by aligning or putting together more cavities, more generators, but also that came with a huge toll in terms of space. Because if you look at the new machines, they are basically quite big, quite large. But if you look inside them, most of the space is taken not by the laser generators themselves, but by the cooling system. So it requires a refrigerating cooling system rather than just a vapor or a fan compared to the first generation. Now, we moved from low power machines to high power machines, but then, apologies. But then the next step was the pulse duration control. We started to understand that the length of the pulse play a substantial role in how we manage stones, how we use our lasers, our holmium lasers. And we started to understand the difference between short pulses and long pulses. There's a short scheme here, or what does that mean? But like always, I'm sorry, this is, okay. The effect is still smaller fragments. Short pulses will fragment more, but you get more repulsion. It's easy to see that it's exactly the same pulse, same joules, so altogether same power. To summarize this, higher energy, longer pulses means smaller fragments, higher energy, shorter pulses means larger fragments. And just for everyone to remember that, I'm sorry, frequency does not play any role in the size of the fragments. So please don't work on frequency when you want to achieve fragmentation versus dusting. Okay, you need to increase your energy. Frequency, theoretically, will just speed up the process, but we'll hopefully have time later on to discuss a bit how we should deal with frequency. Now, pulse modulation was the next step, was, I would say, the third generation of holmium lasers, and you're all familiar probably with the so-called Moses technology, not Moses effect per se, but the modulation introduced by this technology. And it is the idea behind it. Why was it called Moses? Because basically the first part of the pulse splits the water, splits the irrigation, and the second part is delivered more efficiently to the stone and with less litropulsion. So these are the theoretical advantages and practical, I would say, of the Moses technology. Less litropulsion, and more efficient lithotripsy with higher ablation volume. Obviously, that was the first pulse modulation technology available on the market, but then other companies introduced similar modulation. So theoretically, we can modulate the pulse in as many ways as we want. This is playing with me a bit, but I'll... Okay, so we can modulate it in as many ways as we want, but we don't really know, is it a real benefit, or what would be the practical benefit in our clinical practice, day-to-day practice of playing with this modulation. However, what we know so far is that, Moses technology and similar pulse modulating technology together with lower energy and longer pulses will result in less retropulsion. And again, this is a very nice video to look at, and it's quite self-explanatory. Now, the old wizard. But going back to Harry Potter, what has changed? A few years ago, 2016, 2015, we rediscovered a new machine. Thulium fiber is not a novelty. It existed many years ago, and the laser scientists knew about it, and it was used before, but then we, the companies reintroduced it and was again used in endourology, and we have a few prominent colleagues here, like Professor Martov from Russia, who are very much involved in the first assessments and development of these new devices. What is it? What's the difference? It's now not a YARG laser, not a crystal laser. Inside the machine you will have a fiber, so it makes it more stable, less space requirements, and also very importantly, no need for big fans, no need for big cooling systems. You can just use a simple small fan like for a computer machine. And these are the lasers up to 2023. More companies are building more of these machines. So I would say that would be probably one of the most important slides to understand the differences between the lasers that we use. Because we've learned about the length of the pulse, we've learned about the modulation of the pulse, but then quite recently we started to understand the concept of peak power and how does that impact how we use the machines. So holmium lasers, the standard one, have a very, very high peak power. It goes up to 10,000 or even more. With short pulses, it can go up to 20,000 watts, though you use a limited power altogether, the machine, but the peak power is very, very high. And you can see that in green, basically it goes up to the 3rd floor of the hotel, okay? So that is short pulse with holmium lasers. What you see with red is the long pulse. Again, very important, the peak power is substantially lower. So it's up to 2,000 watts. That is why you see less retropulsion when you use long pulses. And then the black curve, as expected, what do you think it is? It's the Moses modulation, which is also relatively, the peak power is relatively low compared to the short pulses. But then the blue one is the TFL. It's very clear, you see the difference. It goes only up to 500 watts altogether, so no retropulsion or extremely low retropulsion compared to the holmium lasers. It plateaus at 500, so it's a very continuous, very stable peak power, and then it goes back to normal. So understanding this, it makes it easier for you to understand what you have to do and how to use your machines in terms of getting the effect that you're looking for. TFL benefits, we've already briefly touched them. Higher ablation speed because a more constant delivery of power, less retropulsion, finer dust because the peak power is very low, so you won't get big fragments, you will get smaller fragments. Also the fibers are theoretically and practically, they can be much smaller, so you'll get finer dust. Theoretically, they reduce the operative time, and safety-wise, they are similar. These are in vitro and then clinical studies. I'm going to jump over these studies because we are already a bit late. I just want to tell you that, obviously, that peak power comes with a disadvantage. It's okay when you want a dust, but when you want a fragment, are they as efficient as the holmium lasers? Obviously, they can't be. So you need to know how to use them in order to be able to achieve similar effects or to be very versatile. So the 3rd generation of TFLs, it has advanced with this, and it advertises a new optimized pulse mode, more effective and faster fragmentation with less retropulsion. So this is where the holmium laser is superior in terms of fragmenting, the TFL is superior in terms of dusting. So the 3rd generation of TFLs want to get a bit more efficient with dusting. So we've got the holmium YAG, we've got the thulium fiber. What's next? The pulsed thulium YAG. Remember, the thulium YAG is a continuous laser. And this is why we did not use it in stones. You can't fragment stones, you will hit them. You're not gonna, it's virtually almost impossible to be efficient with working on stones. So you need a different way of delivering energy. Instead of a continuous wave, you need a pulsed wave. Again, this is not new. It is new on the market for this purpose. It was launched in 2022, 2023, but the technology behind it exists for many, many years. We knew that we can modulate continuous wave lasers and turn them into pulsed, deliver the wave in a pulsed mode. So what is the advantage or the disadvantage? Where's the benefit on using this laser? This is one of the machines. So there are another one. This is basically what I'm going to briefly talk to you about. As you can see, it's somewhere in between the holmium and the thulium fiber. You will get an absorption, so the wavelength is in between. It's more from 2100 with holmium, 1940 with TFL, 2013 with pulsed. Yeah. The most important thing here is to look again probably at the peak power. You see 500 watts for TFL, up to 15,000 for holmium, but around 3,000 to 4,000 for pulsed thulium. What does it mean? It means that it's in between them in terms of being able to fragment, being able to dust, less retropulsion than holmium YAG, but more than TFL. And this is the theoretical part, that practically it is the same. This is a nice example of advertisement from companies. It's a good thing for you to know what to look at when you see a company advertising something. We all owe them a lot. They are helping, they are manufacturing, but they also have to promote their devices. So you have to look into how whatever they say and advertise, it is true, but you have to understand what's behind it. It says 55 more control or less retropulsion overall. But compared to what? Obviously not compared to TFL, but compared to holmium. 7 times more peak power. Again, compared to what? This time not compared to holmium, but compared to TFL. 3 times the speed. Compared to what? Not to holmium, to TFL or to holmium YAG. Holmium YAG has a relatively low speed. TFL can go up to basically thousands of hertz, which is a very, very high speed that we don't really need. Good. I'm going to jump over this and go a bit to... this is a good graph because basically it shows that the pulsed thulium in terms of in vitro performance is very much in between holmium, YAG and TFL. Is capable of dusting all common stones with the production of dust particles quite efficiently. And the last thing that it's on the market is basically a new reiteration of the holmium YAG, okay? And that is the Cyberhole, the magneto technology. It basically has the power of holmium, and they managed to modulate the peak power, something that was supposed to be technologically or technically very, very challenging. And the engineers told us that it's not possible. In the end, they managed to do it. It has pulse modulation, and it has various abilities to control this. But there's one slide I want you to see, and I will try to finish. And this is the slide. You remember, look there, you remember all the peak powers. You see the plateau of the TFL. Look what the engineers managed to do with the magneto or cyber holmium technology. And this is taken from, I'm grateful to Olivier Traxer for this slide. Basically, this is how it looks. It plateaus around 600 watts. You see, it's very difficult to keep this very high peak power laser in this plateau. It's not stable like the TFL, but it stays there. And that explains why you will have a good fragmentation when you want to, because it is still a holmium laser, but also you can get fine dust and you can get low retropulsion, so similar to TFL. That's a summary of what we have currently. Apologies for making this a bit shorter than planned, but thank you very much. And I don't think we have time to take questions at this stage, but if you would like to talk during the break, I'm more than happy to go with through questions with you. Thank you.
Can we have one question, sir? One question? Yes, one question.
One question, okay.
Many of the juniors ask, they wanted to use the laser for RIRS, PCNL, for Staghorn calculus. For RIRS, TFL is good as of now. For small volume PCNL, holmium is good for braking. But large Staghorn volume, still pneumatic lithotripter is better. So many wants to take one laser. It's difficult to fit in all these. Do you think in future such thing can come with these characteristics?
I'll try to be very brief. You saw holmium YAG, TFL, were we happy? We were not happy. So we wanted something that merges, that gets all the good things from both sides. And this is how the pulsed thulium appeared, which is good. It's getting there. So this new technology shows that you can use, I've used it for both PCNL fragmentation, prostate enucleation or whatever. Also, the new modulation, the new reiteration of holmium YAG, which allows us to be much more in control with retropulsion, with finer dusting and so on, seems to be a good compromise. But if in the end you have to decide, it's also how much it costs. New technologies are expensive. So as long as you know how to use your laser and you understand a bit of what's behind it, the theory and the physics behind it, you will be able to use it properly, irrespective of what laser you use. Thank you.
Thank you, Laurian. It was not an easy discussion, but you put it across beautifully. So from the wizard, we move to the next wizard. The next talk is by my good friend, Professor Nariman. And Nariman is doing a live surgery. Okay, so we'll move straight on to Professor Nariman from St. Petersburg. And he's talking about kidney stones with TFL, which is a thulium fiber laser. And he's using a single use 7.5 French scope. Could we please have Nariman?
Ms. Naima Rustamova, your virtual host for today's Congress, proudly developed by the AI Lab at Central Asian University to guide you through this scientific journey. Let's now move into our first academic session of the day, focusing on flexible ureterorhinoscopy and stones, Part 1. In this session, we will explore the latest advancements in ureterorhinoscopy techniques and their applications in the treatment of kidney stones. Our esteemed experts will share their insights and demonstrate cutting-edge practices.
Okay, so do we move on to, should we wait for Nariman or we go on to the next talk first? So I give my talk first? I'm sorry.
Подключаем вики. Так, сколько здесь стоит? Irrigation лист 70 миллиметров вступного столба. Так, вы на этом давлении работаете? На этом давлении? Пока не надо. Сейчас. Ну, отключай, тебе не нужен он. Мы в эфире? Так, доброе утро всем. Меня слышно? Тише, тише. Так, телефоны убрали, ребят. И, пожалуйста, лишние разговоры. Dilmurod, слышно нас? Нет в зале? Доброе утро всем. Нас слышно в зале? Ребят, у нас связи нет, Dilmurod.
Пока убирайте.
Vineet, связи нет. Слышит? А мы можем слышать? Дайте обратную связь.
Говорите.
Нет, так кто нас модерирует? Один Джон, нас слышно? Скажите что-нибудь.
Слышно, слышно, да.
Все, прекрасно. Всем доброе утро. Ассаламу алейкум всем. Большая честь быть в Узбекистане, в Ташкенте. Это мой не первый визит, но мне очень-очень приятно видеть динамику, как растет и развивается страна. Сегодня у нас, нам предстоит показать клинический случай, очень непростой, на мой взгляд. Я думаю, надеюсь, что клинический случай был представлен. У нас, значит, пациентка с морбидным ожирением, с камнями низкой плотности до 500 единиц Хонсфилда, с кислой мочой, значит, камень верхней трети мочеточника до 3 сантиметров и 2 камня почки. Если мы посмотрим на рентгеновский снимок, видно, что камень рентген негативный, что в принципе вкупе со всем тем, о чем я сейчас говорил, можно думать о том, что камень состоит из чистой мочевой кислоты. Это в принципе вселяет в нас надежду и уверенность в том, что даже несмотря на то, что если какие-то мелкие резидуальные фрагменты останутся после операции, литолиз на протяжении месяца при контроле pH мочи 6, 8, 7,1 им почки не останется ничего. Мы начинаем. Мы извлекли стенд, работаем мы сегодня прекрасной командой. У нас операционная сестра Шахиня, у нас анестезиолог Шехзод, у нас полно ассистентов. Ассистировать мне будет Дмитрий Сергеевич Горелов. И мы, собственно, начинаем. Мы первым этапом извлекли стенд. Что у нас там? Ага. Значит, и давайте сразу, бог с ним. Давайте сразу гибкий инструмент.
Давай.
Значит, давайте я немножко представлю то, чем мы сегодня будем работать. Значит, мы будем использовать сегодня уретероскоп, я сам дальше, 7,5 HugeMed. Обратите внимание, очень легкая рукоятка. Инструмент выполняет 270 градусов в обе стороны, плюс имеется ротационный диск при необходимом изменении угла наклона. Значит, также мы сегодня помимо, инструмента сегодня будем работать на прекрасном лазере тулей-волоконном последнего поколения, с возможностью изменений параметров под предпочтение хирурга с различными вариантами и минимальной эритропульсии, и файн-даста, и в процессе операции мы все это покажем. Можем начинать. Так, давайте ирригацию. 90. Да, пока все хорошо. Значит, все, запускаем ирригацию. Ирригация старт. Вода закрываем. Проверяем эффективность ирригации. Ирригация сегодня осуществляется у нас при помощи аппаратной машинной ирригации. Ирригатор компании Шторц. Все хорошо, придержи, пожалуйста, инструмент.
Nariman? Professor?
Да.
Am I audible?
Once again.
Am I audible?
Понятно.
Which size of the...
Значит, мы заходим в HugeMed, значит, без проводников, спокойно зашли в, значит, устье мочеточника. Сделайте, пожалуйста, снимочек. Да. Хорошо, можно на английском. Значит, can you just make it lower a little bit here? Lower, no, here, to the pubic. Good, once again. I want to see where we are, the ureter. Lower. Okay, good. Okay. Проводник. guy wire. Mhm.
Good morning, Nariman. Can you hear us?
Good morning, Vineet.
Yes. So
Nice to hear.
nice to see you all in.
One more X-ray. Good. So we just entered with the flexible scope into the ureter. While we have a proximal urostone, which is up to 2-3 centimeters. Now we're ready to remove the guide wire and go further by ourselves. Good. So the proximal urostone is got impacted as the cross section with the gonadal vein, but we see here the ureter is free. The ureter is free. So here it is. So we see a stone and just let's save it here. So everything will be washed out, the debris after stenting. And see the color. So this is the pure uric exit stone. Absolutely. So what we need here, especially considering that we had a stent here for 3-4 weeks, we need a lower pressure, and we have multiple stones. And this is the perfect case for flexible and navigable urethrosis sheath. Are you agree with me, Vineet?
Yes, absolutely. I wasn't disturbing you. It looks perfect for RIRS.
Absolutely.
That is for sure.
Although the ureter looks quite dilated, we need something active. Otherwise, we'll stay here forever. And after entering the kidney, we have to stay here a little bit, just if we're walking without access sheath. Now I need a guide wire, please. So we're going to put a guide wire in. So we have inspected the pelvic cholesterol system. We have precise indication for stents, and now we're proceeding. Please, a guide wire.
So are you going to put an access sheet as well?
Absolutely, absolutely. We have a clear Petra 11-13 access sheaths, which is perfectly fit for this case.
Yes, especially since you're using a 7.5, it's perfect. Yes. You had a question?
So everything is being done in a stepwise approach. Please take care. And now the access sheaths. Okay. While inserting this fence, you have to be sure that it is assembled in a proper way. Okay. Yes, everything is good. X-ray, please.
In your practice, are
Good.
you using
Upper.
normal access sheets?
Can you see the X-ray picture?
Yeah, we can see.
Once more. Okay. And once again. Good. So we're here. With the flexible and navigable access sheaths, you can insert it up the way into the kidney in the assembled way. So now we're ready and we are connecting the suction tube. Good. We have a floor suction machine, and the pressure should be, we start the suction with a minimal pressure. Please hold the scope, please. And now we're ready.
Great.
Here we are.
Which laser are you using, Nariman?
Can we increase a little bit the irrigation and decrease suction? Good. Yeah, we'll take all the little stones. No rush.
I think you will be done in 3 minutes.
So for this procedure, we'll need a reverse Frendolenburg position to promote the suction. Good. Beautiful.
Do you still
While removing the stones, you have to be vigilant, and you have to keep the irrigation at the same level. So see, the paleocalicial system is not collapsing, so we are good to go. And we're continuing to take them out. While exiting, you have to elevate your tip of the scope so the flow which comes out from the tip of the scope doesn't push them back. No hurry, no rush. You have to close the vent channel, and then you have a very smooth after suction. See?
Very nice, yes.
I think this is the best indication, except the screw stones where you have to keep the pressure extremely low. And we just finished the study on the aspiration abilities and of fans, and it seems that the pressure inside is lower than 5 centimeters of water when aspiration and when irrigation and suction both activated. So we are extremely safe here. Good.
Do you still have a basket with you?
So, once again,
Do you still
we have so many machines here, zooming and making some extra noise. So
Sorry,
I would really appreciate.
we just wanted to know whether you still use baskets or you have stopped using baskets.
Yeah, actually, with fans, you really, very rarely need them. As you can see, we have a very good pressure. The system is not collapsing. We'll do what we can without lasering, and then we'll proceed. Because and we hope to show the laser and the different planes. It is really a versatile machine.
Okay.
Can we show the audience the tissue sensor effect and the capability of the laser? Because it needs a calibration, and concerning our schedule, we don't have enough time for this. But believe me, this is a very good thing, especially for novice surgeons. Absolutely perfect.
Yes, you've already taken out almost 7 or 8 stones, which is fantastic.
And actually, Vineet, I'm so grateful for you for your enthusiasm concerning the fan, concerning the direct in-scope suction. This is a really groundbreaking thing.
This is a good case to have the 11 French access sheet.
Reverse condemnable, please. I want to change the position of the patient. Давайте обратный тренд.
Чуть-чуть поднять. Чуть-чуть.
Yeah, be careful with the line, please. And then elevate the table and reverse trend.
Поднимите стол. Стол поднимите.
Because if you use a regular access sheet or you're working without it,
Обратный тренд.
folio, no, типа folio, да. So the tilt position, which is trend position, is more beneficial.
Стол
If
поднимите.
you use the fan, so we are reducing the gravity. No, device works, guys. Скажи, не отвлекайся, пожалуйста.
Can you tell us why did you change the position of the table, please?
Yeah, actually, so from my personal point of view, which is supported by the literature, it was a very nice study, which I really share the idea of. The reverse Trendelenburg position while working with fans seems helpful for the suction.
Okay.
I don't know, what's your view on that?
I I personally have never used the reverse Trendelenburg for fans, so I'm not.
Because this is the siphoning effect.
Okay.
Good. So we're very close to begin with lasering. Actually, good. I have to check. It seems like so here the angle is very good for us. So it's not acute. We don't need to relocate it. So I think there will be no problem getting in with the tip of the fence. So good. I want to make the puncture study just for a short while. Please stop the irrigation and stop the suction. I need to check the system. So to be on the safe side, to be sure.
Yeah, it's a good idea to have one check before.
Yes, absolutely. Снимать? Yazma. Good. Good. See?
Can we also?
Do you see the picture, the X-ray picture?
No, we can't. We'd like to see it. Yes, please.
Yeah.
Nariman, good morning, Dr.
Yes.
Chandra Mohan. Dr. Chandra
Good morning.
uh,
Irrigation and suction.
what type of irrigation you are using? Are you using gravity or?
No. As I said before, maybe it was in Russian. So it is a machine irrigation with a short pump.
Okay. You routinely use pump?
Yeah, actually, so we have a nice study. I mean, showing that with the machine irrigation and with fans, this is the safest combination in terms of pressure. So you hardly can elevate your pressure more than 5 centimeters of water. This is the thing. So here we are in the lower calyx. So actually, we have a 90-degree bending kit, but if you apply some force and dexterity, you can go up to 140 degrees. And I saw the X-rays from Vineet. He can do magical tricks, moving the tip of the fence wherever he wants. I cannot brag with this because actually, and I will show it later today, sometimes the scope can fail just during this maneuver. This is the problem. And that's why I'm eager to relocate the stone first.
No, I think it's no correct way. If you want to relocate. If you don't want to relocate, it's fine. It also depends on the scope. If you are not going to use the scope again, if it breaks, no regrets. But if you're going to reuse the scope, then it's better to relocate because there can be a lot of damage sometimes.
And look, guys, I want to bring your attention to here. So see a small stone. So never let the stones leave behind the scope. Otherwise, your scope can get impacted. I was sharing this video recently in my Twitter channel. So I had a very, very problematic case. So be very careful. Because sometimes the scope and the stone can get plugged in the fence. So be very careful.
Yes.
So Dilmurod tells me that we have 5 minutes left, guys, and I'm trying to be as fast as possible, but please give me your questions. Yeah, lasering, yes, of course. Thank you, Dilmurod. Yeah, can I have a laser? So I will finish the case without you unfortunately, but I want to show you how perfectly this laser works. And I'm free of any conflict of interest. I really admire this machine, guys.
Any question from the audience, please, if you want to know? We will convey the question, please.
So, considering the stone density, we see that this is pure uric acid stone. So we'll work in the regime of minimal rate repulsion, very light stones, and very soft stones. And we'll go with the dusting. Can you show the laser settings, the camera, please? Which is 0.4 joules and 20 hertz, which makes in total 8 watts, which is far beyond the limit of the lasering regimes in the kidney. Can I have a lasering pedal? So this is the left pedal settings and the right pedal settings. We'll go with popcorning. And actually, so we have so many names of pop dusting, fine dusting, etc. So the thing that you have to remember, I'm just trying to bring the attention of the audience. If you want to dust something, you go with the small joules and higher hertz. If you want to break something, you go with the higher joules and less hertz. Okay, we're ready to go? Yes, please.
Okay, ready.
I want you to increase a little bit the irrigation. So we know that bringing the laser fiber into the working channel decreased the irrigation almost half. So good, good. Now it's good enough. Thank you. Shehzod, can I have an apnoe, please? Good, thank you. Look how nice and smooth it goes to the dusting. So
are you using the suction as you dust as well?
actually, the vent is open right now, although you see there is no dust and the suction is already happening. It's not in the same manner as we when we close the vent hole.
Excellent.
But actually, with the fans, it has no sense in dusting, in my opinion. So we have to make a fragment instead. So I just wanted to show you, even this uric acid stone, it's not moving. Look at it. So the movement is so small. So the rate repulsion is so low.
Sure.
And now we'll go to the fragmenting. It will be 0.8. It will be 13 hertz, and it will be short pulse. Look at it now. Fantastic.
Yep, definitely very nice. Well, the wizard is Nariman.
Look how nice chipping is.
Nariman, we will probably in the next couple of minutes have to shift because
we'll finish this case in no time. Good.
Yeah, so
very good, fantastic.
So we expect you to finish in 2 minutes, which I think definitely the way it's going should be. So it's actually very fast, the surgery now.
Yes. With this equipment, with this team, it is a pure pleasure case.
To the moderators, we are sorry, we'll have to make a small change in the program because our next speaker, Guido Kamphuis from Amsterdam, from the biggest university hospitals in the Netherlands. In Amsterdam, he is probably the most prominent endourologist in the Netherlands now. He is going to operate. He starts his operating list today, and he needs to deliver the presentation before he starts the list, if that's okay with you. Apologies to you, Vineet. So we will, after that, we will continue with your lecture. We will skip my lecture and we'll do it later on during the day, okay?
No, perfect, all right.
So
I think we should,
Guido is already here with us, so Vineet, you can take over from here. Thank you.
Perfect. welcome, Guido. It's nice to see you. I hope you're all set for your lecture. We're all excited to hear from you. And since we have you online, we will pass the baton to you straight away.
Fantastic. Good morning, everybody. Thank you for the opportunity to present a bit early, and thank you for the great invitation to be part of this. I've been watching the presentation and the online surgery by our colleague with enthusiasm. It looks great. So my presentation today will be on URS in ectopic kidneys. Do you see my screen?
No.
I'm sharing presentation now.
Could we please see Professor Guido's screen over here? So for the audience, we have a topic now from Professor Guido, which is on ureteroscopy in anomalous kidneys or ectopic kidneys. And it's coming straight from Amsterdam. But we would like to see his slides, please. Is your screen in full mode, Guido?
It looks like, yeah.
Okay, so perhaps there's something from our side. Could we?
I will try to stop and start again. Maybe that helps.
Sure, please. Are you sharing it again now?
Yep, I'm sharing it again.
Okay, please bear with us. We are just trying to see why we can't see it over here. Okay, we can see you. Here's your first slide introducing you and URS in ectopic kidneys.
Yeah, exactly. This is the first slide.
Okay, please
Fantastic.
Carry on. Thank you very much.
And now we can see if we can also start it. So thank you for the nice introduction. I'm trying again. These are my disclosures. Can you see them, Vineet?
Yes, we can. Thank you very much. Yes,
fantastic. So these are my disclosures for lectures with companies I've worked with and advisory board meetings and institutions I'm working with. And I'm very happy today to have been able to bike to my hospital, be ready for the list later on, and share with you the insights from Amsterdam. This is the hospital. We have been merged with 2 academic centers in Amsterdam, and I'm now sitting in a small room at the right side. So the definition of an ectopic kidney is when the kidney is not in its usual place, out of place from ancient Greek. And the definition, what type of ectopic kidney is depending on the anatomy. So where is the kidney positioned at the moment? And there's a difference with the renal ptosis, where the kidney was initially in its proper place, but moved downwards with its normal anatomy. So the incidence is quite normal, high incidence of average of 1 in 900 people. And it's important to see the lower part, the last sentence, that there's a incidence of genital anomalies in patients with an ectopia quite high, of 15 to 45%. Important to know is that the length of the ureter, very important for ureteroscopy, as you will know, conforms to the position, so rarely redundant of longer than normally. And also the urethral orifice is normally positioned in its anatomic place. The arterial and venous network, however, are anomalous. So it's important to get information about that before you start your treatment, especially if it's not ureteroscopic. So the diagnosis is like most patients with kidney stones, but the pain can be a little bit in a different location and more abdominal, in contrast to normally positioned kidneys, urinary tract infections or hematuria. The incidence of stone in ectopic kidneys has not been established, and the pathophysiology is probably as in normal kidneys, with some extra emphasis on the possibility of having stasis of urine inside the collecting system. What EAU guidelines say in an abnormal position, try to have a CT scan with contrast to reconstruct the anatomy, especially of the vascular structures. Indications for stone treatment are as in normal cases. What I would like to show you is a case, a 40-year-old man who has moved to the Netherlands some years ago and was already known with ureteritis bilaterally in his country of origin. He had the PCNL on the left side for 2 times, 13 and 3 years ago, and an open pyelotomy on the right side on the pelvic kidney 13 years ago, and then a ureteroscopy 6 months ago, which was not successful, and he is complaining about hematuria and lower abdominal pain. In a case like this, you're already warned. He had multiple surgeries before, and especially the open pyelotomy is something to consider. And here you see a nice pelvic kidney, and on the outside you see a scar, obviously, of his in his lower abdomen, and after PCNL, and he has 2 stones in his right kidney and a nice lower pole stone in his left kidney. And here you see 2 CT scans with different phases of contrast to see the vascular structures, but also the anatomy of the collecting system. Then, because of the previous surgeries and how the kidney looks, we also make a nuclear scan to see about the function. And he has still a nice function of about 40% of his right kidney. And it's important to know that a lot of those ectopic kidneys already have a little bit diminished kidney function. So he was known with uric acid stones, like Nariman was showing previously, but in his medical history. But now he has a HU of 1100 to 1400, and his urinary pH is normal. So probably these stones are not uric acid stones. And there's surgical history and his scar tissue, and also anatomical position make it difficult maybe for PCNL with interposition of bowel. So we decided to treat his best kidney first, the left side, and prepare the right kidney for the next procedure. So that's what we did. Here you see a ureteroscopic evaluation of the inside of the left kidney, and we did a combined procedure with the miniaturized PCNL, clearing out that kidney. And then here you see a X-ray of the pelvic kidney on the right side. So we place here a guide wire with this semi-rigid scope. We give contrast. Here you see the collecting system filling, and we place the double J. And on the position of the double J and also the length, you see we placed a normal double J in an abnormal kidney with a redundance of double J. So we should have placed maybe a smaller one, but it did its trick. So we checked after this procedure, the left kidney was stone-free. The double J was still positioned right. It was uncomplicated. And then we planned to do a ureteroscopy on the right side. So the anatomical considerations for flexible ureteroscopy in these kind of kidneys is that the renal pelvis is most of the times more anteriorly positioned. You can have a malrotation of the kidney and a high insertion of the ureter, and access may be challenging. So I think these are the cases where it's not a bad thing to do a pre-stent, which we don't normally do. But in these kind of cases, you have the optimal accessibility of the ureter. This is a nice study already some years ago by one of the organizers, Laurian, showing that in a benchtop model, different flexible scopes have been tested, and they are not all the same. So this is a study from 2017, so with all the models until 2016. And nowadays, there are more and more scopes at the market. But keep in mind that they're not all the same. So they have all their different specs, their pros and cons. So try to have the scopes ready for these kind of cases where you have the optimal flexibility. And back in those days, there were not so many single use, only one. But nowadays, there are more single use scopes. And because of the anatomical challenges, you can break your scope. So it would be a good idea to have a good flexible single-use scope at the ready. So here we went on with our case, the second procedure, ureteroscopy on the right side after pre-stenting. We placed the guide wire, we have an access sheet in, evaluated the ureter, looks normal, gives some contrast. And here we start with the Flex XC, evaluating the kidney. Unfortunately, I don't have any images from the inside, but we have been looking, we found one stone, we treated the stone, but then we didn't find the other stone. So here with the flexible scope contrast study, we see that there is contrast around it, so we expect to find a stone. We switched to a P6 fiber optic scope from Olympus and evaluate the kidney, but could not find the second stone. On the inside, after the open pylotomy, there was scar tissue. It was difficult to navigate, and we said we have to accept that we cannot find it. We're gonna first see how he's doing afterwards. So the CT scan post-operatively, you see on the left side there's no stones anymore. On the right side, you see it, and it's a bit disappointing, obviously, that we found one stone but not the other one. So we did a metabolic evaluation. He had a good diuresis after all the advices that he got already for years and years because of his recurrence KSD. Some mild hypercalciuria, hypocytruria. These were calcium oxalate stones and some calcium phosphate in the mix. And the man was rid of his complaints. He didn't have any abdominal pains anymore, no hematuria anymore. And he said, well, there's no guarantee for success. Let's keep it like that. And now 4 years later, he had a recurrence on the left kidney for which he did a shockwave, and the stone in his right kidney is stable and asymptomatic. So going back to literature, this is a review published some years ago about outcomes of ureteroscopy for stone disease in anomalous kidneys. In a systematic review of only 413 patients, 117 of them were ectopic. And what you see is that, and it's a retrospective, it's a high risk of bias, low quality studies, but you find that if you have the proper indication, flexible ureteroscopy can be a really good option with a low high risk complication chance. So there are 70% complications, but the majority of those are Clavian 1 and 2. So flexible ureteroscopy in patients with anomalous kidneys can be technically challenging, but offers effective outcomes with good stone-free rate and low risk of major complications. Thank you for your attention. Maybe we have some time for questions, I don't know.
Thank you for the excellent presentation. It was super succinct but super nice because it's really challenging. If there's anybody in the audience who would like to ask a question to Dr. Guido, please feel free. We do have a minute or two to take any questions. I have one question for you, Guido, is that which scope in the current market, if you had to go back to do this case, would you like to use? Would you like to use a 6.3 or a 7.5, or does something make a difference for you?
It's a good question. We still have a good reusable scopes ready. If we have a patient who is pre-stented and we can place an access sheet, I still really like to use a Flex XC. It's a great instrument to work with. The moment that you see you're forcing or you're pushing your scope, you feel really reluctant to push your reusable scope too much. If you feel that you have to go into a calyx where you see it's there, but you cannot reach it with your Flex XC, I still like to use a fiber optic scope, but you can also say, okay, I'm going to use a single-use scope. There are many on the market. We use the Poussin 7.5 regularly. And what you do is you use not only your active flexion, but also your passive flexion to glide and slide into that area, which is a little bit different technique where you wouldn't do that because you're afraid you might break the scope, but in a single use, you're less reluctant to do so. But you have to keep in mind that if you break your single use scope, you still have to be able to take it out in one piece without damaging the patient. So it's not only about being careful for your scopes. The most important thing is to be careful with your patients, obviously.
Thank you. Thank you. That was well explained. Any other questions from anybody else? Laurian has a question for you.
Actually, it's not going to be a question. I just wanted to thank Guido for joining us. Guido, hope you have a good list today. I know you've got a couple of complex cases, so good luck for today. It was a pleasure to have you with us. Thanks again. For the room, I'll have to...
Thank you very much, and good luck with the Congress.
Thank you. Thank you. Now, we've been running a bit late, so we are not going to have an official coffee break. I would like Vineet to kindly go ahead with his presentation, but those of you who would like to go and have a coffee, apologies, Vineet, we may reduce a bit your audience, but I hope you'll excuse us. So those of you who would like to have a coffee, you feel free to have a coffee now. Those who want to stay in the room, feel free to stay in the room, okay? We will just carry on with the program. Thank you. Thanks.
Thank you. Thank you very much. Do we go ahead with the talks? In front of me. Okay. All right. So once again, I thank the organizers, everybody here, especially Azim, and for this wonderful opportunity. We've been seeing a lot of discussion regarding lasers. We've seen some complex cases. So obviously we are talking about the next step in endourology, which is perfect in Central Asia. So I'm going to talk about direct in-scope suction. Basically, this is something where you've seen that the lasers create a lot of dust. So now we are trying to see how we can move from dust and get things a little bit clearer. These are my disclosures. I'll come to the... Okay. We just move it forward. Okay. We saw the first talk which showed you have two beautiful lasers and then you have many more. But any laser that you are using is going to create a lot of dust. And this kind of dust is fantastic, but you have to still remove the dust because sometimes it takes time for the dust to come out and the dust can stay back. Now, whether I'm using the TFL laser or whether I'm using the high power holmium laser, all the dust, especially when you go bigger, will hide some pieces of stones behind. And that's where we find that we miss a lot of stones. Okay, so there's too much dust, and then you're trying to remove the dust, so you're going on flushing the fluid, then you're increasing the pressure, you're trying to use higher lasers, now you're increasing the temperature, your vision goes away, and then patients have a sepsis. And this is really where we start to worry when we start to do cases. Like there's too much dust, what can we do about it? So if you have too much dust, we decided, when we say we worked with the team and we said, let's just get rid of the dust. Is there a better way to do it? If you can get rid of it through the scope, and that's the concept of direct in-scope suction. This was something which I proposed in 2022, and now it's really picking up slowly because fans or flexible navigable sheets have become bigger, but it's something that it's there in the armamentarium. So we look at a little bit of the evolution before we move forward, but I can't get the slides to move. Okay, so this was how it all started. We just used two IV adapters connected to your scope, add suction, add aspiration, and it works. When we start looking at this in a more practical way, if you look at this study, which was the first study, we're using the same thing that I showed you, there was no sepsis. And that to me was the main reason I said, perhaps we have something interesting and something to build upon. So we reached out to the companies and we worked on it and we realized you really need fine dust. So we told the companies, can we do something which is basically what we were doing with the adapters, and we can bring it into a scope. And the Busan company was the first company which liked the concept. This was new because it was the first time in single-use scopes. It was already available in reusable scopes. Many of us use cystoscopy, so we had suction. So it was good to have something which you can use in flexible ureteroscopy. So once we spoke to them, of course we had to do all the studies to see whether this is a concept which works. It took 1.5 years before we could actually start to do some studies because production was slow. But once people understood that this is a concept, we now have all the evidence to tell you that the pressure is low, the temperature is low, you need fine dust. You need dust. And the dust definition was by Professor Traxier from their university. They said 250 microns, which is really like very, very fine dust. And then this dust will come out when you suck through the scope. Otherwise, the working channel, which is one working channel, where you have a laser fiber, you have irrigation going inside, and you have suction through that, is going to get blocked. And remember that this is why this is a procedure which has not gained its rapid momentum because you're using one single channel. But there are ways to counter that as well. So with that, the terminology of this was well established. And then we decided, how do we improve on the technique? Now this is where we did the first multi-center prospective study. And these were the outcomes that we could correlate. And I will show you with this video as you watch. This is a case which you saw like Nariman went in. There was a bit of debris, it was pre-stented. It had infection inside. We kept an access sheet just below. And then we realized that you can actually first remove all the debris around the stone. You can suck it out through the scope. So there is no access sheet which is sucking, it's just the scope which is sucking out all the debris. So first you clear the whole system, and that way the direct in-scope suction helps. If you do it through the scope alone, you may not get all the debris. If you keep an access sheet, it will flow out with the irrigation and intermittently aspirate. Now you can see the stone is coming under vision, and you can see actively suction going on. And this was something which was done in Professor Bhaskar's team. And then I just took the video because when they called me up and I said, yes, I think it's something you can do. So they carried on with the case. And Dr. Amelia was operating, and we were there. We were just watching them doing it. You can see everything is fluffy, and this was not a case which you would prefer to do RIRS, or you would say, let's do a PCNL. If you maintain eventually in about 5 minutes, and this is real time, everything starts to get very clear. Once it starts to get clear, we start using the laser to then dust the entire stone. For some reason, it's looping the video. I'm not too sure why, but you can see the surgeon is just making everything clearer to get a focus of the stone. Okay, I hope it goes to the lasering part, but otherwise I'll move forward for the lack of time. Okay, you see the stone, and then you do what Nariman did. You take the laser, you make it into fine dust, and you can carry on. We were able to get rid of the stone fully. We were able to get rid of all the dust inside. We were able to get rid of all the debris inside. Okay, it's looping. So if you look at evidence today, there are two different things. The problem is blockage of channel, which is a real part, but it's a single channel. But if you make it into a double channel, or if you can make it a bigger channel, maybe you can get over with it. Again, the problem with this dusting is you need very, very small powder. But most studies will tell you, or which are at least about 10 or 12 of them, that you can get a 96.5% stone free. It would be best to use this for stones which are maybe best for ESWL, and as you gain experience, then you can increase the size, maybe 1.5. I know Chandra has an amazing experience with pediatrics. I personally really think this is one area in pediatrics as well that it works excellently. There are now studies which we are doing it with and without the access sheet to see how best we learn. But the evidence has to still speak for itself. We spoke to the company, and because we were thinking, because it's a small channel, can we have a bigger channel? So they came out and they made a 9.2 French. So you're compromising on the diameter, but you are increasing the working channel size to a 5.1 French. So there's more flow coming, and there's a bigger channel for you to aspirate. It makes sense. Both of them should help you to do a better in-scope suction. We are now working on the evidence of this. The first in vitro evidence that we could see was that even with the laser occupancy inside, you can still get the dust coming out, which you could not earlier with the 7.5. So there was no blockage. So one hurdle we were able to overcome. If you use a smaller laser fiber and more irrigation, you can actually get rid of dust, which is even up to 300 to 350 microns. Which is also great because you can now get slightly better. So if you look at sometimes the small pieces of stone, you can actually use the scope and move the particles from one part of the kidney to another. So sometimes you want to relocate the stone, that also is possible. Interestingly, you can even get rid of 4 millimeter fragments with an axis sheath inside. So with this, it became interesting to now see how do we make direct in-scope suction better. So you have a scope, you have the lasers, you can make it into fine dust. To make it into fine dust, we've already explained, you really need to make sure that your laser is a good pulse modulated laser. It's not about high frequency always, but high frequency tends to make finer dust if you move faster, but don't exceed the frequencies which are dangerous in the kidney or in the ureter. And I think there will be more talks discussing that. So if you look at future trends, can we then integrate suction into robots? It's already happening. We are working on this in a team with Hong Kong. Can we integrate AI into this? We are working with a company where they will identify which pieces of the stone are more than 2 millimeters or 3 millimeters, so you can actually break them into small particles if you need to. We are increasing the suction ability within the scope with the existing channels by using certain pneumatic suctions, which will be coming into the scopes next year. And then we are also introducing this into pediatric suction scopes. If I show you what I do, which I think is an easier way to use it practically, is I integrate both. Why do you have to select fans? Why do you have to select this? And when I looked at how do I do this, okay. So you combine both. You have a suction mechanism on your sheet, you have a suction mechanism on your scope. Again, I hope the video plays. So when you go to the parts of the stone which you need to fine dust, you can clear it with fine dust, with suction in the scope. When I find I need to remove those big fragments, I just move the suction to the sheet. And if you look at those kidneys over here, all these are surgeries which we were able to get done using this combination, which we may have done PCNL. I still like PCNL, but sometimes the patients now come and tell you, because they've gone through the literature, we would prefer to have RIRS. What is interesting is you can actually get rid of the stone in one sitting. I don't believe in doing a surgery if you cannot get rid of all the stones in one sitting. If you cannot 100%, then choose another way of doing the surgery. So to me, that's the single most important criteria. Not only that, if I was the patient, if I go to the hospital, I will now demand the doctor, I need to see my CT scan early because I need to go back to work. So I want everything to be clear within the next 24 hours because it's a day surgery. So this is where combining both is one way in which suction in the scope is really, really helping. But yes, there are a little more expense. You have now a sheet and you have a scope. So don't use it for every case. But these complex cases, once you have enough experience, you may try and you will find presently that you will have very good outcomes. We also decided that why do you have to make one scope which you reuse and throw? We want sustainable engineering. So we decided to invent a system where you can fix it to any scope and that can become a suction scope. And why do you want to make it big? If you can carry that machine and keep it on the table next to you, which can do everything. That means it can regulate the pressure, it can regulate the flow, it can regulate the suction, even better. So we did the first study for this, and it was quite successful. But again, it's only a pilot study. We then decided we shouldn't restrict ourselves with, technology is always good to keep moving, except for the technology here. Okay. All right. If dust is the criteria and the laser is the criteria, can we invent a laser which can make finer dust? So then, and you don't want to go, as was told by Laurian, you don't want to increase your frequencies or increase your power. You want lower power because you're dusting the stone, you want it to come within 3 to 6 watts. So just by changing the angle of the beam, we now have dust in a simple setting. In your clinical setting, you can actually generate dust up to 80 to 100 microns. That dust doesn't even need to be sucked out. It will just flush out. So you can actually modify the laser, you can modify the scope, you can modify the technique, and you can do a good direct in-scope suction. We then decided if this is going to be no more a challenge, can we do something even more exciting? Okay, we'll move on. Yeah. Can we bring back the concepts of dual channel scopes? And presently you will find that the dual channel scopes will be out next year. So now you have one side of the scope which is doing everything that you were doing with the 7.5, and the other side which is giving you suction and irrigation only suction. And this is being modified in the dual scope. The dual scopes are there, but this is a modified dual scope. This is good because one side you're not disturbed, you just do what you want to do, the other side is removing everything. And this is again with 2 or 3 companies, and you'll find that this will be coming out, but they will be 8.2 French scopes. So we have 7.5, 9.2, 8.2. If you like the sheath and you like the scope, and we just told you that why can't we have one system make a new scope which can do everything. So this is a prototype that you are seeing which is being developed. And if you look at this, you can actually, it's something like the CVAC was trying to do, with some of you may be familiar. I have no experience with it. It's too big a scope for me, and I'm personally not impressed. But if I can do it with the 7.5, and I can actually have something like an aspiration catheter, which we put in when you have phlegm in your, the anesthetist use. So we can actually start using that and remove everything. If I can bring the suction into a 6 French, a 6.3, a 7.5, even better. And companies are working with us. 6.6 is the smallest that we managed to get, but you will see that this thing gets better. So it doesn't stop because suction in scope is not dead, though flexible and navigable sheets are more exciting. But you will see all these technologies coming in perhaps maybe early next year or by end of the year. So I think today, if you ask me, I think then the answer is, does it help? Well, yes, for sure, if you know how to use it. It has potential future benefits. It can be used combined with ECAs, combined with PCNL. I don't think it's a substitute for it, but it can be used in any hospital setup. Some of us work in very big hospitals, but some of us are working in smaller centers. And to just come to what's important here, I would personally think if somebody is trying it out, it takes 5 cases for you to realize how to use the suction in the scope. You need to navigate the pressure, navigate the irrigation, navigate the suction. I would suggest keep at least 100 ml per minute of water because you need to flush out everything. When you are sucking, remember if you're using the 9.2, the system will collapse even faster than a 7.5. So you need to balance that out. Sometimes it will get blocked. It's very easy, flush, and then you will realize. We have now systems which can tell you when it is blocked. Fragments will not pass, so you know if the case is not dusting very well, this patient needs an access sheet, change to an access sheet, or use it with an access sheet. Because sometimes some stones don't dust very well. And to me, I think this technology is now coming with intrarenal pressure control. We finished the first study using this with IRP. It's fabulous because now I can spend 100 minutes inside the kidney and not worried that the pressure is getting challenged. So that's where I feel the scopes are equally good. And we have some multi-center evidence which will be coming out. Hopefully we will share that with you soon. Thank you for your patience. The next talk is yours, Laurian. Will you be doing it now?
Amazing talk, Vineet.
Ladies and gentlemen, we are now moving on to session 2 of the day, continuing with our focus on flexible ureterorhinoscopy and stones, part 2. In this session, we will delve deeper into advanced techniques and emerging technologies used in the management of kidney stones. Our expert speakers will present live and recorded surgeries, providing valuable insights into the evolving landscape of endourology.
Good, so our amazing AI assistant already announced the next session, but before we actually move to it, is there any question for Vineet? This was an amazing presentation, so take advantage. We can take one question from you guys. Come on. Okay, I'll ask quickly. So lots of things that you're gonna present and introduce next year, Vineet. What is your favorite project out of the many projects that you're running?
I think when the one which I showed you where you integrate the sheet into the scope, so for reasons I can't declare what it's called, I think that will be super exciting because you get the best of both. It's going to be an integrated suction sheet scope. So okay. It's exciting.
And the laser that really makes very fine dust. Perfect. Thank you very much again. Thanks to the moderators. Very good session. Well done. My talk is going to be later today. So we'll move to the next session as our amazing AI host announced, and I would like to ask Dr. Hae Do Jung from Seoul, Dr. Kassymov from Astana, and Dr. Yunusov from Tashkent to moderate the session, please.
Good morning, everyone. I'm Hae Do Jung from South Korea. Thank you for inviting me CAEC25 and congratulations. So now start session 2 of our scientific program. So flexible ureteroscope stones, part 2. Our first presentation is pre-recorded surgical video. Please welcome Dr. Chandra from India. He will demonstrate on RIRS case utilize the pulsed thulium YAG laser, fence, and single-use 7.5 frame scope. Please, Sandra.
Yeah, respected chairpersons and my dear audience, I first of all congratulate the organizing team of this Central Asia University scientific program on stone. My topic today is semi-live video with 7.5 French disposable scope. I'm sorry, I use thulium fiber laser. I have recorded accordingly. I apologize. I will continue the video. It is 12 minutes video edited. Various aspects we try to finish. I have given 15 minutes time. I will finish in 12 minutes. After that, we can have some questions. Thank you, Ajmijan, for giving the opportunity. As you all know, flexible and accessible navigable sheath is approximately 50 centimeters, 45 centimeters, 40 centimeters of various sizes it is available. If you put 50 centimeters, most of the times you can reach all the calyces. If you put 40 centimeters, you can reach the pelvis, but sometimes upper calyx may not be reachable. Disadvantage of using a long access sheath is most of our scopes are standard size 70 centimeters. If the 70 centimeter scope goes into the 50 centimeter access sheath, the working part of the scope will become short and you will not be able to use it. This is about the size. The evidence I am reflecting in first few slides, it is obviously evident that all different type of stone volumes, the fans access sheath is used. Now second point, as Professor Nariman was showing, whenever you have difficulty in lasing, go with this sheath up to the stone, keep the stone just few millimeters from the mouth of the access sheath, you will get very good result. The only problem is you touch the laser inside the access sheath and damage it. These scopes and these sheaths are single use. It's not for multiple use. With this introduction, I will show in this video without voice, where I will be interested to speak on myself while the video is going on. This is approximately 1.5 centimeter stone in the left kidney. Whenever you do any case, read the CT scan carefully, as it is semi-live video. 130 kg patient, ideal case for RIRS, ideal case for fans. So when you read the CT, if multiple stones are there, if any pus flakes in the ultrasound are present, any multiple densities are there, be careful. This is the access sheath, which is 50 centimeters long. There is a side channel for the suction. There is an obturator. If you remove it, you can put the sheath through this rubber cap so that it will aid in the suction. And the tip is very sharp. Assistant should not push it inadvertently. This is the disposable 7.5 French huge med scope, no conflicts of interest. This scope is slender. Check the flexion and extension in the beginning. And when you put in the, this is important point, in the access sheath, how to flex it? Do you flex with your flexible scope? Usually no. You thread over the flexible scope. If you want to flex, let it be inside the access sheath. See, if you do like this, scope will damage. You have to do like this, 1 millimeter, few millimeter inside the sheath. Now, I use 20 ml syringe with an experienced technician or preferably urologist. Less contrast is required, rigid ureteroscope is required, stent removal is done with rigid ureteroscope. Preferably use stent in all the cases whenever you are doing in the initial cases. These are the laser settings, 1 joule 10 Hz TFL super pulse thulium, 0.1 joules and 60 Hz for the dusting. And the popcorn technique is also important. You change here to 0.1 and 100, which becomes 10 watts. These are the 3 settings to do the RIRS in any format. Now I am removing the stent. If you feel, you send the culture if the patient has diabetes or any other clinical symptoms of UTI, and you pass the guide wire and assess the ureter even in stented cases. Reason, stone might have come down, small fragments might have come down. Directly inserting the access teeth is not good. Just like Professor Nariman has shown today, use ureteroscope, pass a guide wire, then this is the way you pass the access sheath. Ensure that the tip of the obturator is probably placed. Direction towards the left and right assess. Use the C-arm. This is the only place where C-arm is essential. In rest of the RIRS, you need not worry. But here, 5 seconds, use the C-arm. Ensure that the sheath is in proper location. If it is in the pelvis, the guide wire curls and you hit the kidney, be careful. It may perforate the calyx. Once it is done, the suction is normal OT suction with 100 mark. You attach to the side. There is a hand movement where suction can be done. Flexible ureteroscopy movements are predominantly wrist movements. They are not elbow and shoulder movements. Most important movement is the front and back movement, which is done with your left index finger and thumb. It's up to you, but it's okay. Most important movement is the front and back. And the second movement is the internal rotation and external rotation. Third movement is the flexion. Not the flexion is the main movement. That's the way you can keep reusable scopes more steady. Now the laser fiber should be inserted, check the movements, and then go inside. You can put the laser fiber keeping back the flexible scope in the access sheath. Now, after checking all these, you go inside with the laser fiber inside the flexible ureteroscope. Once you go inside, hazy vision will be there. Use little bit of pressure, things get clear. So this is the stone present. The sheath is just below the stone for better water logistics. If you keep sheath in below the PUJ, it becomes practically non-fans RIRS, no use. If the fan sheath is kept just below the stone with these laser settings are variable. My laser settings are these. Minimal movement, internal rotation, external rotation is important. The laser fiber should not be too much outside. If it is too much outside, see, this is mug present in the initial time. After 5 minutes, everything will be clear. That is the advantage of suction method. Any RIRS in stented cases, you will see dust initially, some flakes initially. Let them be sucked and start the case. Don't do hurriedly. Let everything suck intermittently. Now see, this powder is coming. A question comes, should we make fragments or powder? Take it for granted, both will take same time. But it looks good if you do powder like routine RIRS and then keep on suction without stopping. It is better. As the procedure comes to an end, when the stone becomes less volume, then automatically they become small fragments. You cannot do anything. With whatever laser settings, with whatever laser, invariably stone will become small pieces. That is the time when this fans RIRS is very useful. Otherwise, you can do initial part with normal sheath, then switch over to the, see, this is the suction collector of the stone attached by sideway. All this powder is sucked spontaneously without any problem. 80 to 90% of the stone comes out as powder. 10% of the stone comes out as small fragments. The size of the fragment which can be sucked are 2 mm ideal. If you suck larger fragment, it will take time. You have to use more pressure. Nariman today was using for the small secondary stones. They are easy to be sucked, but fragments sometimes get stuck inside the sheath. You put more pressure, then entire purpose of fans RIRS is gone. The person who is flushing, the person who is sucking, the person who is doing surgery should have all common point that the water should come out immediately. In future, artificial intelligence may come, but normal intelligence of human being is enough. If the calyx is going away from you, not good. If calyx is collapsing and coming into your eyes, not good. Around 1 centimeter distance, continuously if you are maintaining, chances of time wastage will not be there. At the end, you can go to each calyx, you can clean all the fragments. It's like mopping the floor. And with this, only suggestion which I give is, if you have doubt, stent it and do RIRS later. If you have doubt, stent it, do RIRS later. Because the fans sheath minimum size now is 9.5 by 11.5. So it is big for Asian ureters. If you stent in large volumes, you will save lot of ureteric damages. So take this point and go with this fan sheath, it is easy. At the end, if you want to put the stent, we put the small stent 3.5 French with ureteroscope without using CAEC. To conclude, in this case of fans RIRS with disposable 7.5 French flexible scope, CAEC is used only for 5 seconds during access sheath insertion. That also can be avoided, but better use appropriate times. This is the powder and that is the fragments. So with this, lot of people in Asia are using, urologists are using this fan sheath. My one more suggestion is, don't use second time. Use only one time. To conclude, optimal laser settings of TFL is very important. The suction and pressure irrigation should coordinate each other with the surgeon. And if you have any problem, convert it to normal RIRS, put the stent, nothing will happen. It is only to make stone-free rate less. Thank you.
Okay, thank you, Dr. Chandra, for nice lectures. In this video, what is laser type? TFL?
TFL.
Okay. Any questions from floor?
I have one question. Okay, we have a question from floor. Dr. Jahangir, please.
Thank you, Dr. Mohan, for your wonderful presentation. So nowadays in our country, it's often we can see the younger urologic surgeon who performs the RIRS surgeries, and we are in our practice we oftenly see some complications of these surgeries. So here in the audience there's a lot of young urological surgeons, and the main question is what is your recommendations like for the young surgeries to avoid complications such as damaging of ureter and others? Thank you.
That's very important question. Dear juniors, whoever is starting within 2-3 years of your practice, be careful in assessing the ureter. Professor Nariman has passed the flexible scope first. Ureter distensibility is very important. If ureter is very good in the beginning part and last 2 centimeters it is tight, all your purpose of RIRS will go. Please do understand 3 things. Ureter should be distensible. Water should come out. Outflow should be there within 5 minutes. You infuse 400 to 600 ml of saline in one RIRS surgery. Imagine if the water doesn't come out. Where will this go? So output is the most important. We published. The pressure depends on output. And second, if you don't have vision, if everything is hazy and bloody, stop it. Do PCNL or put stent and come out. Number 3, never forcibly push the access sheath to satisfy the patient for first time RIRS. Don't do that. Explain the intricacies, minuses of the RIRS, that it can be staged. Patients do understand. Juniors feel sorry to put the stent and come out. Seniors feel good to put the stent and come out. So dear juniors, put the stent when you have doubt. Save the ureters. Next time you will have much, much better. Stone will never cause immediate morbidity to the patient. Thank you.
Thank you. Okay, thank you.
Thank you.
One more question there. Okay.
One more question.
Yeah.
Okay, just one question.
Thank you for excellent lecture. Doctor, I want to ask about the pre-stenting before the RIRS. Is it obligatory? And if it is obligatory, which method do you use? Just cystoscopy or the ureteroscopy way you will place the stent?
Yeah. Putting stent is a preliminary procedure. You use cystoscope, you use ureteroscope, no problem. But my request is whether to do under anesthesia or not, whether to inform the patient or not. My suggestion is first 50 cases of RIRS, put the stent, don't do ureteroscopy, put the stent. Come after 15 days, you will be much less stressed and you can do better performance. First 50 cases. Once you get experience, you will know which sheath will go. So I don't want to do ureteroscopy if I have to put a stent, because simple ureteroscopy can cause sepsis. Whereas cystoscopy stenting is better. You do that day, within 1 hour, you can discharge the patient under local anesthesia, and second procedure is the main procedure. First procedure is very, very small procedure. Tell that within 1 hour you can go. But if you do ureteroscopy, pressure will rise. Rigid ureteroscopy is dangerous because it is one way flow. It cannot come out. So don't do ureteroscopy, put stent, whatever size, no matter, but with cystoscope. Am I correct? You are,
Yes.
yeah,
Yes.
thank you.
Okay. Thank you for your answer.
Thank you very much.
Dr. Chandra. Okay, next presentation, next report. It's from Singapore. It's Dr. Vineet Gauhar. Funds are they here to stay? Please.
Thank you again. So we will move from one spectrum of direct in-scope suction to the other spectrum, which is fans or flexible and navigable sheath. If I can have my talk here. My timer is running, but my talk's not here. Okay. So I'd like to thank a lot of people who are in the room and not in the room, but all these people have worked together with me, and we've got an association for developing fans. And the reason, of course, these are my disclosures again. Okay, so we have guidelines which tell you based on the size of a stone, which is a better way to do RIRS if you take only RIRS. We have all these proven details which we know, 2 centimeters, you need to have a good laser, you need to have good training opportunities. So what's happened with that is RIRS is the fastest growing in urology surgery today. And some companies tell me that every 1 minute there's 1 RIRS happening in the world, which is a lot of RIRS happening. So technically, why is that important? Because we have all these important parameters that we need to consider when we do RIRS, and yet we are struggling sometimes to get the patients 100% stone free. The difference between a good RIRS and a great RIRS is 0 fragment RIRS. So 0 fragment means your aim as you are training should always be in your mind, my patient should have no stones, no fragments inside. I don't like clinically insignificant, clinically significant. I thought that was the worst thing to happen to literature. But at that point of time, we didn't have a choice. We had to have something to guide us. So let's guide us with 0 residual fragment. And the reason I say that is because this is data from the best of surgeons. When we looked at it from their data, which is, as you'll recognize, quite a few names, even they had to go back 50% of the times to do a second surgery. And that re-intervention to the patient costs money. And if you're going to use a scope and sheath and all those lasers again, everything adds a lot of anxiety and a lot of cost. So the reality check, when we looked at every single detail from this study, we realized that it doesn't matter whether you have a good RIRS, doesn't matter you have a good scope, a good laser, you have a lot of experience, you're excellent, you have best of baskets, you will still have fragments inside, especially when the stones get slightly challenging. And the stones don't have to be in a challenging anatomy, the stones can be hard, they can be slightly complex, and they can be placed in locations you can't reach. So the problem is we need something to change all this. Now on top of it, we also have a lot of fantastic evidence to tell you, you need to regulate pressure, you need to regulate temperature, you need to regulate the amount of time that you spend in surgery, and you must have a vision throughout. So you need one thing, and how do you do something which you cannot keep on making new technology which takes care of temperature, takes care of pressure, takes care of this. You need one technology. You need one thing to tell you, this will take care of everything. So that's when we started, again, every time, please, make it a habit for the juniors. Go back to literature, look what is missing. It will give you an idea to think differently. When we looked at literature, we realized that we need one solution, and the solution probably is suction. And this was taken up from PCNL, because PCNL has been the time-tested and the gold standard of care, and suction mini PCNL has shown to give us excellent outcomes. So can we bring it into ureteroscopy? I showed you direct in-scope suction. That is one way of doing it. And the reason it matters even more now is that we are now making more and more juniors do RIRS because they find it to be an easier surgery to learn. So, as of today, we have 2 concepts. Initially, it was called the flexible tip suction ureteric access sheath. It is a flexible tip, but when this concept came 3 years ago, it was Professor Zheng, it was an omnidirectional. That means one direction can only go in up to about 18 to 20 degrees. It cannot go all the way to 200, 250 like we do with the scope.
So I said, let's just talk to the companies and see whether we can make this better. And then we said we want to have automatic systems which can make our surgery easier, but that's for another discussion. I showed you this earlier. Zero sepsis with direct in-scope suction, but you still can't get 100% stone free. And I told you at the beginning of surgery, a good surgery is when you have nothing remaining inside. So if I have to leave behind 10% residual fragments with direct in-scope suction, I need something better. And I still want all these concepts. I need to have something which can get rid of everything. This was my reason why we spoke to this friend of mine when they were using the single sheath, and I said, are you sure that you can control the intrarenal pressure? So I was witness to him getting this experiment done, and I said, we really have something that can change the whole game. That's when I contacted Dr. Saeed Hamri over here, and I said, hey Saeed, you have the sheath in your company, which is the old one. I'm going to send you a new one, which I'm developing with the company. Let's work on this. And we called it the flexible and navigable because that's what your scope does. So you can take it down into all parts of the kidney, and the concept of flexible and navigable suction sheath was born. We wanted to standardize the term because it's something which you standardize and everybody can report outcomes. We know it's good, we know it's bad, or we know it's not to be done. But if you look at all the literature, unfortunately, even today, people are calling it different things. And these are good centers. Very happy to know that with the recent meeting that happened in China, everybody is of the belief that fans is perhaps an easier way to remember things. So it's good we have one terminology. When you have one terminology, you can do a global study. Then we reached out to all our friends across the world. Many of you are here. We said, let's do a study because I can do it well, Laurian can do it well, Chandra can do it well, but can everybody do it well? When we reached out to many centers, they participated. Then we came out that in normal adult kidneys, most of them were pre-stented, you can actually get zero residual fragments. What surprised me that in 97% of the cases, there was zero sepsis. So there are two win-win factors with the flexible and navigable sheath. Zero sepsis to me is more important than zero residual fragments. What was interesting is then, can you use this? And we started to do all the studies to understand, can the flexible and navigable sheath be used in lower pole stones? Which laser is better? Which sheath size is better? Which scope size is better? What can it change in practice? Should be done under general anesthesia? Should be done under, which one? And finally, in the meeting, it was then said that yes, the suction has been coming in, the sheets have been changing, but the flexible and navigable suction access sheet last year is perhaps the real game changer because it can bend in every direction. It used to be two directions, and the next generation can actually go front and back. And you can then actually lock it in different places. So the sheet is also changing. And that's why things will change. And I'm really grateful to Azim as well, because then we started to even test it in pediatric cases. Remember, Azim, we used to speak to you. And now, if you look at publications, RIRS is happening only with fans, almost everywhere. Because literature is supporting the evidence saying that yes, zero residual fragments, zero sepsis is a reality. Once you have literature which is running parallel for two different technologies, it increases the ability to do more studies, more meaningful studies, because I want to know how long does it take for a surgeon who is a junior, first year, second year, third year, what are the things that I need to improve? You saw Dr. Nariman do a surgery. It's true. You can actually get rid of multiple stones. He did it in the lower pole. He did it in different parts. So fans is changing the way we are doing RIRS. It was a 20-minute live time that he was given. In 15 minutes, he got rid of almost 12 stones. This was not possible before. So fans really changes the way that we can do surgery. The question given to me by Azim was, are they here to stay? I think it's pretty obvious that the answer is simply yes. What's changing with fans is important. We can now do larger stone volumes. Larger stone volumes means more time. We can now stretch the time from 60 to 90 minutes in the kidney with the safe option. We are able to do it in bilateral stones in children, and patients' quality of life is improving. This guideline, which does not include the concept of stone volume, and what is really a big stone is going to change because we have now suction in there. And they say, perhaps it's time to rethink how we approach the stone for RIRS. So fans and fans-like concepts are changing things. There's always technology and there's always technique, and everything needs to be improved. I'm working towards some of these key directions, but what I would like to bring back is when you look at the original paper which did surgery in 300 patients,
We actually did surgery even for stones like these, which we were not thinking about. This was a case for a suction mini PCNL. But there were surgeons who were told, it's okay, just do what you want, let's look at the outcomes. Even with these kind of cases, you were able to get a 97% stone-free rate within one sitting. Most of them were actually within 48 hours, which was amazing. So if I looked at this and I said, can RIRS really change the way, or is it time that we say the suction sheet is the only way to do it? The suction sheet was the one which you were used to keep it and used to suck, but you could not go into different parts of the kidney. With fans, honestly, I think all the other access sheets are almost dead. But fans, of course, will change. Now, this study was just published 2 days ago, as you can see over there. Even with PCNL, it's actually comparatively good. Where we thought to see, can fans stay? Because, you know, it could be a novel thing today, but it will become something obsolete tomorrow. We are now able to even do complex stone cases, which are guys 1, 2, 3. What we are realizing is, wait till you do the CT scan. Don't be in a hurry to do a CT scan the next day for complex cases. And in 4 weeks' time, which is a good time to wait, even guys score 4, which is the complex anatomy which Guido showed you, in those kind of stones as well, you can get it off. The reason I say in those kind of kidneys, you now have sheets which are 8.5 centimeters. You have a next generation sheet which is going to be 7.3 centimeters. And with that, with 7.3 French. With that, you can actually navigate almost every system because scopes are getting smaller. 6.3 was the limit we thought, and now you have a 6 French. And if you have visited the huge med, they have a 4 French key. So I think technology will change how things work. We did a really nice study with Chandra's help, and we looked at fans in patients, and this was using adult systems. Even with adult systems, we did a great job. And he has an excellent paper which will come out, which has now got pediatric-only scopes, pediatric-only sheets. So fans is changing even for adults, it's also changing for children. If I look at it from my perspective, because I have quite a bit of experience in this, I started to do it in bilateral, and I said, can I get rid of these bilateral stones? And if you look at the CT scan over there, we thought we'll do stage surgery, but we went ahead and we published a paper where we said you can actually get rid of all the stones on both sides because you can spend longer time in the system. I don't advise you to do this in the beginning, and I don't advise you to do this in the end of the day. This should be your first case when you're fresh to do it, but you can do it. That's the point. So if you can do it, and it's possible in a single stage, then we published it. We again reached out to friends who are doing it. We said, hey, can you do it? And let's see what the outcome is. You still have a 90% chance of having at least one side 100% free, and 65% chance of both sides free, depending upon the stone size and stone volume. But only 1% re-intervention, 0 sepsis. That's fantastic. So you don't have to go back in. When we look at the subset data in this, even patients who are in Singapore, where I practice, most of my patients are at least 75 years of age. And this is for RIRS as well. In older patients, I don't want them to come back to the theater. I want them to finish the surgery in 1 day. When we started doing these complex cases, we said, do I really need to put a stent? If I can do a good surgery, I started to avoid stents completely. So this was a patient who was pre-stented before, but after surgery, I just kept a 24-hour ureteric catheter, took it out. And this paper was then recently published where we had a series of about 70 cases. In the right patient, you can decrease the amount of exit strategy stenting. None of you in the operation, none of you over here will like to have a stent before and after, then go back in for a second surgery. So that's how fans is also changing things. And this is something which I think is the single reason why perhaps suction really benefits. Because it doesn't overstress the renal capsule, there's no pain. If you don't create an injury, there's no fragment inside, there's no sepsis, the pressure is low, why stent the patient? So I think there's a good way in that. And what we did with this study was we stopped giving analgesia, we stopped giving antibiotics, so none of our patients get it unless they actually need it. And that's another paper which we'll be publishing. And so this was where we pushed the limit to its maximum. This is a fellow who's been seeing me for 10 years. He came in, he's a daily wage earner with that kind of a complex anatomy. It jumped. He's got kyphoscoliosis. If he doesn't go to work the next day, he's not going to earn money. We can get rid of the stone, no stent before, go in, clear the surgery, no stent after, he goes back to work in 36 hours. It was only possible because we had fans. And we feel that it's going to really, really change, but the question that they asked me in European Urology was, do you need suction sheet for every case? It's a very difficult answer to tell you.
you're going to use the sheet, please use it carefully because the sheet will still cause injuries. And I know Saeed will be jumping to give that presentation. Sheet and injuries don't happen because of the sheet. Injuries happen because we create the injuries. So you can decide whether you want to use it for every case. I'm not sure. But my personal opinion is it is probably a good thing to use. So yes, it's going to change clinical outcomes. This is a paper that we published where how is it evolving the sheet. I've been fortunate to work on it from 2020. And it's going to change. If you look at those complex sheets which are there, these are actually, which we thought will only come in 2026, are already there in the market. They're already available, I think, even here in probably, they're all pressure monitoring sheets. And it's going to change again. The whole anatomy of the sheet is going to change. We'll see this as early as probably 26 January. So with that, probably, I think this is something which we saw with in-scope suction. In in-scope suction, somewhere possible. In fans, it is 100% possible. So I would say yes, yes, and yes for everything, which is pressure, temperature. So that one slide I showed you in the beginning, one treatment for everything, 100% fans can take care of all that. What I feel is going to change is the bigger stones. So the PCNL versus RIRS is where it's going to change. At this point, almost everybody who has done at least 10 cases with experience will give you this result. This is universal, which is a great thing to see. But again, it's normal kidneys, it's not an abnormal kidney. And a simple thing, what we changed, we just changed the way we do RIRS. We brought the sheet and the scope to the kidney instead of trying to bring the stone to the surgeon. This paper got published just 2 days ago, and this was the first non-inferiority study which clearly said that fans is as good as suction mini PCNL in up to 3 centimeter stones. And I think fans are definitely here to stay. We'll skip for time that there's a lot more evidence that we are generating in terms of pressure. I just want you to remember this figure. If you're going to use suction, you need to know everything about all these concepts. If you don't have knowledge about these concepts, you may not do a good surgery. You may not get the outcomes we're talking about, and then you may wonder whether the technology is really good. So please, for the juniors, kindly go into detail. Training is important, and you have excellent teachers here, and I think guidelines will also change because of this. So thank you very much for that.
Thank you. Dr. Dohat, thank you. Very interesting information. Dear colleagues, do you have any questions?
I'm sorry.
Thank you.
Thank you for nice lecture. I have one question. How do you set irrigation fluid pressure and suction pressure during using fans?
Okay, so the simple rule is start with at least 100 milliliters per minute. That's the minimum amount of irrigation. And you need 10 millimeters of mercury, or roughly around 76 kilopascals, depending on where you work. This is the minimum amount you need to keep the system distended. If you have stented the system, it's a hydronephrotic system, it's a complex system, you only have to increase more, not decrease. That's important.
Thank you.
Thank you.
Thank you very much.
So our next speaker is Laurian Dragos, and then pre-recorded surgery, retrograde internal surgery for kidney stone with TFL.
Good, thank you very much, Vineet. That was amazing. The incredible thing about this meeting is that we have innovators and people with an amazing view into the future, like Vineet here, and also we are literally privileged to have Professor Alkan with us here, who is one of the biggest figures in endourology and the legend in endourology. So, Professor, thank you very much for joining us, and applause from the... You basically shaped endourology, so thank you again. If I have my video, we are a bit late with the program. Luckily, I did put my video on an enhanced speed, so, and I'm going just to talk over it. It is literally the last case that I did before I come here, so I don't have the CT scans. I just jumped over it because of time. I'm talking about a 1.8 centimeters stone and a smaller one in a young patient. Looking at the stone, you will tell me what kind of stone it is, and looking at these ureteric orifices and the struggle that we had, let's guess what's the history of this patient. This is kind of semi-live surgery, so it is edited, but instead of putting in taking out the awkward steps or the parts of the surgery which is not so good to show, I did exactly the opposite. So I did show the unpleasant bits, the things that happen in real life, okay? So look at these ureteric orifices. How do they look? The stone is in the right kidney. I'm trying to get to the right kidney. You saw that basically the right ureteric orifice was on the left side of the bladder, the left was on the right side. So the patient had ureteric reflux and had ureters re-implanted when he was very young, and they were crossed, you know, the method, the old way to prevent reflux. So the left was opening on the right was opening on the left. Though he's a young patient, he had this in a different country when he was very young. Now, you saw that I went in, we managed to cannulate the ureteric orifice, but if you saw, there was very difficult to use a straight wire, and then we used Albaran scope to push the ureteric catheter into the ureteric orifice. But even with an Albaran scope, the trick was to use a curved tip wire to be able to cannulate that UO. It wasn't easy. After that, access sheath, you saw a flexible access sheath, and we get up into the kidney. I showed you the setting of my theater, and obviously we connect the suction and we start. At this stage, it was my registrar who did this part. He couldn't cannulate the ureter, so I stepped in, I put the wire in, and then I asked him to carry on with the procedure. We did a brief semi-rigid ureteroscopy, and then we moved to the flexible ureteroscopy. You saw that the system was not dilating, obviously, with the suction sheath. Even without the suction, once you place the sheath inside the kidney, it gets deflated, so there's low pressure. So what kind of stone is this? Who can take a guess very quickly? Come on, I'm not going to ask the moderators. You saw it very briefly. It's quite typical. What stone is that one? Cystine stone, exactly. I think I'm quite brave to come here and show you a cystine stone with a TFL laser. Actually, cystine stones are quite a challenge for any laser. If you don't know how to use the laser and to respect some principles, they are not the easiest stones to manage. And you have to understand that the sulfur bindings in the cystine stones are quite elastic. So they don't break as easily, and when you cut them with a laser, you tend to have this charring effect on the stone, less with holmium, more with thulium. So if there is a stone that you need to know how to use your laser on, especially a thulium fiber laser, it would be a cystine stone. But what I wanted to show is that you can use a TFL on a cystine stone quite efficiently, as long as you know what you're doing. So this is my resident, my registrar, my trainee doing parts of the procedure. He's trying to follow my guidance. I'm behind him talking to him. And the setting was, did you see the setting briefly? It was 0.5 joules and 10 hertz. So I would say very low frequency for considering what the laser can do. Why? If you increase the frequency, all the charring that you'd see is going to be much more significant, and it's going to be much more difficult to use the laser. Then at some point, I step in, I manage to put the sheath over the stone and fix the stone as my previous speaker very, very nicely showed. I changed the setting, I increased the energy a bit, knowing that I will have more charring, but we need to finish the procedure and saw the stone in one go. Okay? The key is distance to the stone. Don't bury the tip of the laser into the stone, and don't stay in the same place. You really need to move across the surface of the stone, while the distance issue is a bit more challenging to manage compared to a holmium laser, because you have to be in the optimal distance to be able to get a very good effect. But it is perfectly doable. You see, once you are in the right distance, then the stones breaks quite nicely with a TFL, and the settings are probably a bit strange for you. It's 0.8 joules and 10 hertz. Now, a few tips and tricks. You saw the bubbles. They are quite typical. Even if you don't see anything, if you see those bubbles covered with whitish layer, you know this is a cystine stone. You don't need to see more. Then taking fragments out, same thing as Nariman. Congrats, Nariman, by the way. You did a very, very good procedure. It was amazing to see, look at you. Now, what we did here, I just wanted to show how good is this laser with coagulation. There was a very small fragment of stone embedded under the mucosa, and we lasered it, and you see there's basically no bleeding with TFL. Okay, so from this perspective, amazing tool, especially if you treat upper tract urothelial tumors. One of the things that you might have noted is that sometimes you get these fragments, and a good tip, I'm not sure if the previous speaker mentioned it, though he was very good with tips and tricks. A good tip would be to keep the stone, keep the sheath in, and then go retract the scope a bit inside the sheath, stay like 1 centimeter in, and start lasering those fragments while you aspirate, and you see that the fragments just are fragmented, they are made even smaller by using the laser, and they will just be aspirated, suctioned. At the end, there was this very challenging, it was a lower pole, anterior lower pole, acute angled. So the last fragment, we took it out with a basket because it was, almost 90 minutes of surgery altogether, condensed in 7 minutes. And it was, we didn't want to leave anything behind. And obviously we put a stent. So I'll stop here. Probably we have a couple of minutes to take questions.
Thank you, Laurian, for a nice demonstration. Is there any question from the audience? We have one question.
Thank you for your lecture, Dr. Dragos. I have 2 questions, if it's possible. Yes. One question about condition which is cause for cystine stone in this patient. And the second question is connected about how did you plan this operation? I think such kind of operation should be planned thoroughly.
So it's cystinuria, okay? It's a genetic condition, and these patients have to be followed up for their entire lives, and we have a special clinic run by nephrologists where they are managed and they are given proper medications, and obviously their lifestyle is different. They really need to drink. If you ask someone to drink a stone former to drink 2 to 3 liters, you will ask a cystinuria patient to drink 3 to 5 liters of fluids every day, which is very, very difficult, isn't it? So they have to understand their disease, and they have to know how to manage it. So there's lots of guidance that we can provide on top of. So it's not managed just by urologists, but we have this special clinic with nephrologists where we manage these patients. Second question is how you plan it. You need to understand the CT, location of stones. Sometimes we do 3D, but it's the first time when I operate this patient, but I will definitely operate him again. So I kind of start knowing. So it's good to have continuity, to know the patient's kidneys and know the tips and tricks and the pitfalls. You saw this was quite a particular case. Not a good thing to have a cystinuria when you've had this reconstructive surgery previously. I would say understand the patient, understand the architecture of the kidney or the urinary tract, and have all the tools and devices that you need at hand, and try to clear everything as much as possible, take all the stones out.
Maybe some specific tips in such kind of, because in this case we have two challenges, as you said, this kind of anatomical challenge and cystine stones, and in such kind of things, what can you recommend? What maybe some specific tips?
I did give some tips. If you have a more specific question about what exactly are you thinking of, I did provide some tips on how to cannulate this specific ureter. So I used, in the end, I started with a normal cystoscope, but then I used the Albaran cystoscope, where you have the bridge that you can direct the ureteric catheter. And then even with that, with a straight tip guide wire, it wasn't going in the right direction. So I used an Albaran bridge and a ureteric catheter and a curved tip Terumo type wire in the end. So lots of single-use devices that you end up utilizing for these patients. But next time, I will know, I will go directly for this setting instead of losing time trying to cannulate something that you can't cannulate otherwise. Anterior, lower pole, acute angled, very difficult. What happens is that when you push your scope, especially if it's a long trajectory downwards, the scope goes like this and like this. And when you want to use the flexible axis sheath, then you won't be able to get there. So you need to, once you place the scope over, you keep it bended, and then you start pulling a bit the scope downwards, so you smoothen that acute bend of the scope. And only after that you advance the axis sheath over the tip of the scope to get to the stone. If you saw the first part done by my resident, he wasn't able to push the axis sheath over the tip of the scope. So the axis sheath was somewhere in the pelvis. The tip of the scope was going like this and this into the anterior lower pole. When he was trying to push the scope over, the sheath over, the tip of the scope went up. So he was just lasering there. When I took over, I just pulled a bit with the scope bended and then pushed the tip over the, but single-use scope, as my predecessor said, single-use scope, single-use sheath. Also, 6.3 scope, so I had quite a lot of space in between, and the sheath was 10-12 French, so I had quite a good space in between the scope and the sheath on the inside.
Thank you.
Thank you.
Good.
Thank you, Laurian. Thank you.
Thank you.
Эта наша сессия состоит из 3 частей. Значит, мы сейчас переходим на часть дебаты. Спасибо нашим модераторам. Приглашаем, пожалуйста, доктор Muzaffar Tukhtamishev, Yodgorbek Safaev, Jamshidbek Halilov. Пожалуйста. The topic of debate is: do we need to stone measure? Do we need to measure stone volume? Introduction by Muzaffar Tukhtamishev, then Dr. Yodgorbek Safaev is yes, and Jamshidbek Halilov is no.
Good morning, esteemed participants, dear friends. It's a big pleasure to welcome you all to the first Endourological Congress. And I'm so honored to stay here among such dedicated professionals, professors from over the world. Although it is the first Congress, I hope it will not be the last. And today we have prepared some debate cases, and one of them is, do we need to measure the stone volume? Firstly, we should know about what is the stone volume, because there is a confusion that it is one single dimension diameter and the stone volume. And the stone volume, we calculate stone volume taking into consideration that the stone is roughly ellipsoid, often using the formula or multiple the 3 dimensions.
Okay, this formula, in order to calculate, gold standard is the CT scan. And in three-dimensional 3D imaging, you can see from this slide. Today, you all know that urologists often debate that whether the stone volume measurement necessity or not. So today, two of my colleagues will debate about this challenging problem, and for yes will be the Dr. Yodgorbek Safaev, and for no, Jamshidbek Khalilov. And after their arguments, we'll come back and together we'll conclude.
Thank you for introduction. And dear colleagues, I am happy to be here, and I would like to thank organizers for this opportunity. I have no potential conflict of interest. And when it comes to importance of stone volume measurement before surgery, there are several points to consider. Precision in planning, prediction of outcomes, optimization of efficiency, and improved risk stratification. What did we find in the updated guidelines? Unfortunately, there is no direct recommendations on stone volume measurement here yet, only hints so far. But we can find a lot of publications in respected journals that supports our point of view, and this slide shows the results of a study that includes data from more than 500 patients. This study examined the role of stone volume in choosing the most appropriate treatment method. And as we can see, for stones between 10 to 20 millimeters in size, it is more meaningful to use stone volume measurement instead of diameter. And another slide shows the results of a study that examined the role of stone volume in predicting shockwave lithotripsy outcomes. As we can see, this stone volume was the most useful predictor during the study. Another study, another big study, and it is also important to remember that the larger the stone, the more important the density of the stone will be. This slide shows the results of another study that examines the role of stone volume in outcomes of retrograde intrarenal surgery. As a retrograde intrarenal surgery being increasingly used as first-line treatment of larger stones, the inclusion of stone volume measurement in diagnostic standards is only a matter of time. As we saw, recent literature emphasizes that stone volume rather than linear dimensions alone significantly correlates with surgical complexity, stone-free rates, operative duration and complication rates. And when talking about risk stratification, we should focus on that fact. Prolongation of operating time is one of the key factors in the occurrence of complications and is in most cases associated with a large volume of stones. Thank you for your attention.
Good afternoon, dear colleagues. Today I will argue that routine measurement of stone volume in kidney stones is unnecessary and in some cases even counterproductive. Okay, let's start. Historical context. Let's begin with fundamentals. For decades, stone size has been assessed using maximal diameters, and it works. The European Association of Urology Guidelines 2025 and American Urology Association 2022 still rely on diameters in millimeters, not volume. For treatment planning, millions of successful surgeries have been performed based on this metric alone. Simplicity of diameter. Why? Because diameter is fast, simple, and universally available. Measuring takes less than 10 seconds on computer tomogram. In contrast, volume estimation is complex. It requires 3D segmentation, bone window, reconstruction, sometimes manual formulas, or advanced tools like the kidney stone calculator. This increases radiologist workload and delays surgical planning. Technical limitation of volume. More importantly, most centers don't have certified 3D segmentation software. And even when they do, the variability is significant. Inter-observers differences of up to 6%, inter-observer up to 4%. In other words, the same stone might be reported with different volumes depending on the radiologist. Now, let's talk about relevance. Volume doesn't not always reflect surgical complexity. For example, stone in lower pole calyx, 12 lower pole calyx with 1,400 can be more difficult to remove than 30 mm Stockholm stone with 400 density. Why? Because density for the pelvic angle and location have greater impact on success rates than volume. Okay. Risks of over-reliance. Blinding relying on volume can lead to our treatment. More PCNLs, higher complication rates, greater hospitalization burden, and increased costs. Okay, guidelines, and here's the key point. Neither the European Association of Urology nor American Urology Association guidelines recommend using stone volume in routine treatment algorithms. They focus on diameters, number of stones, location, density, Hansfield. When volume is useful. So, is volume ever useful? Yes, in selected situation. When dealing with multiple stone in academic studies and quantifying Stockholm stone burden and artificial intelligence-based predictive models. Our conclusion. In daily urologic practice, volume measurement doesn't accelerate diagnosis, doesn't improve outcomes, and cannot replace surgical expertise. Therefore, I firmly stand by this position, no. Stone volume shouldn't be measured routinely. Let's focus on the truly matters, diameters, density, anatomy. There's a simpler, faster, and more reliable. Thank you.
Thank you, colleagues, for your arguments. And I think the measurement of the stone volume, it's still debating and challenging problem because although there are a lot of publications in favor of measurement of the stone volume, but AUA or the European Association of Urology guidelines, they recommend they use millimeters instead of cc. But anyway, in my opinion, in our opinion, you can. Can you put, please, Yes, in my opinion, most of you have seen this picture. In this picture, at the first glance, it seems that the lion is eating its cub, isn't it? But in reality, you can see that lion is taking care about its cub. So in stone measurement, we can also take into considerations from all angles as this picture and use all dimensions. And taking into account all arguments from our colleagues and recommendations, measuring stone volume is especially necessary when there is a multiple staghorn or irregularly shaped stones. When are you planning surgery? Because larger volume stones may require PCNL rather than URS. And stone volume helps predict operative time, complication risks, and outcome. And when we shouldn't measure the stone volume, if there is a solitary, small, and regular shaped stones, less than 1 centimeter, a single diameter may be sufficient for treatment planning. Thank you very much.
Thank you. Is there any questions or comments from the audience? So I would like to comment that measuring the stone volume is very important for the planning, the surgical time and the surgical outcomes, because sometimes this 10 millimeter stone, which is in the city, which may be 200 cubic millimeters if it's spherical. If it's staghorn shaped, maybe it may over than 500 cubic millimeters, which may relay the surgical time and or some septic complications. So that's why we are totally agree with you to go with stone volume measurement. So sorry for Jamshidbek, and then thanks to Yodgorbek for the comments. Thank you for great debates. Thank you.
Thank you.
Question. Sorry. There is one question. I'm sorry.
Not a question. Just a comment. My point being that you have to measure the stone diameter as per guidelines using a CT scan. So if you are going to do a CT scan for endourology, you might as well measure the stone volume. It will take you 10 seconds more.
Yeah, sure.
Thank you. Thank you.
Thanks.
So we will move to next part for roundtable, the radiation exposure in ureteroscopy, ALARA principles. So I will invite the faculty, Dr. Vineet Gauhar, Dr. Said bin Hamri, and Dr. Shuhrat Mukhtarov. So let's start to talk on the radiation. We are endourologists, almost we are working in face and then under X-ray exposure, so which is very important. And in our real life, we have a lot of publications and a lot of cases which is related with some complications related with X-ray exposure in our colleagues. So that's why today our task is not only work with X-ray or without X-ray and how to decrease it, and then how it's related with our real life. So please, Dr. Vineet.
Yeah, Azim, I think it's an important topic which is not discussed much. We just take it for granted that we are wearing a lead shield and most of us will probably wear an apron, we will wear a thyroid shield, and that's about all. We believe this is enough to protect us, and we also are aware of the principles of ALARA, which is as low as radiation, which is acceptable. But when you take it into practical consideration, you remember that it is not just the surgeon who's getting exposed, but it is also the other people in the operation theater. So sometimes following radiation protocols is not only good for you, it's also good for your accompanying surgeons and as well as the nurses, etc. So as a practical standpoint, in our residence training, we have one separate session where we teach about radiation first. So every trainee should understand what is important about radiation. And it is true, radiation may not cause cancer, but radiation does cause a lot of harmful effects. So radiation is also protecting yourself from the injuries that can happen when you are using too much of fluoroscopy. A simple thing is to tell your radiographer, either you can control the radiation, which is the X-ray, or you can tell your radiographer to narrow the imaging field so that you only focus on the area of interest. There's no scatter, it's called radiation scatter. The second thing that you have to tell them is to reduce the frame rate. Every time you press on that, sometimes it takes 20 photos per second. You don't need 20 photos to reconstruct the X-ray. You need 6 to 8, which is more than enough. So that's I think, a simple strategy to start. Your table distance from the C-arm is also equally important. You don't bring the patient too close to the C-arm, or you don't keep the patient too far away. You maintain the 8 to 15 centimeters depending upon the size of the patient, and that should be usually more than enough for the kidney. So these are the starting practical points for, and this is for all endourology, RIRS. PCNL, of course, there's a slight difference because you have to move the fluoroscopy. And I think ultrasound-guided PCNL is probably a simpler way to avoid radiation.
Thank you. Доктор Шуратурсунович, что вы думаете насчет рентген-облучения во время операции?
Так, слышно меня, да. Вообще, насчет радиации, я бы хотел бы сказать, что лучше, конечно, это мое мнение, я не хочу опираться на пока физический момент радиации. Когда начинал эндурологию, мои учителя говорили, лишний раз не наступай на скопию, но никогда не забывай себя контролировать. То есть, когда специалист начинает заниматься уретероскопией, уретероскопия это то же самое, как нефроскопия. У нас на сегодняшний день имеется очень много методов, которые могут вам показать расположение мочеточника и ответить на те вопросы, которые вас могут заинтересовать во время проведения операции. То есть, если мы сейчас говорим о камнях, то наличие камня предположительно определится, как долго он стоит и прочее. Поэтому, в принципе, я в своей практике стараюсь лишний раз на скопию не наступать, радиацию не использовать. Единственное, если бывает необходимость выполнения установки стента там, или установки катетера, вот, напоследок, там буквально, может быть, даже доля секунды, только определиться, где это все расположено. Просто с годами человек, когда занимается эндурологией, он немножко по-другому видит мочевую систему. Он не в 2 оси, а в режиме 3D уже рассуждает. И когда занимается уретероскопией, когда занимается каким-то инвазивным вмешательством, он уже в голове чувствует, в каком отсеке, как ему надо двигаться. Поэтому если все-таки наступают моменты, когда какие-то преграды, и есть необходимость определиться, необходимость включения или рентген-контроля, я согласен с мнением нашего предыдущего коллеги, то есть максимально снизить дозу облучения, уменьшить поле обзора и постараться поменьше наступать на скопию.
Rahmat. So, Dr. Said, there is some words, ALARA.
Yeah.
So why is this ALARA developed? What is it, ALARA? Can you comment on that and why we need it in our routine practice?
Really, I would love to say Assalamu alaikum first. I'm a victim of thyroid cancer and I have a cataract. I removed my thyroid 2 years ago. I was so busy since my start by late 20s doing a lot of x-rays. I believe if you are doing more than 200 procedures per year, you have to reduce it. Nowadays, after I had these problems, I start to use the ultrasound for PCNL. It's a very good tool. You have to wear the goggles if you are doing more than 200 procedures or you've been assisted to that. It's very important as well not to forget that the X-ray is very important for the early training for the young endourologists. X-ray is important. You cannot work without it. KOLs who is exposing no X-ray or fluorescence operation, they have in their back about 2,000, 3,000 cases. But at the beginning, you have to protect yourself. As Vineet said, you have to decrease the field of and you have to take in your hand the X-ray, because if you say to the technician, do the X-ray, he might be late, then he missed the point, so he exposed you more. So I would love to say again that taking care of your health and patient health is the same. So patient needs an X-ray, but you need to reduce it and to take the measures to wear everything, the thyroid shield, the complete shield, and you have to understand that this shield should be changed every 3 to 5 years. You cannot throw them on the floor. I know I visited many countries where they threw these shields on the floor and they broken. So they are not protected anymore. So you have to call your radiology department and ask them to test them. There are some tests to do, is this shield is good for you or not. Do not forget to hang it very well. Do not throw it on the floor or put it anywhere. Thank you.
Thank you for comments. I would like to do some questionnaire here because we have practicing urologists from the over than 10 countries. So давайте будем честно отвечать и руки поднимать, что вот многие из вас практикуют там эндоурологию, уретероскопию, перкутанную хирургию. Кто в конце операции смотрит на CR и смотрит на время рентгена? Кто из вас? Только по-честному. Ну, я думаю, здесь всего лишь там 5%. I asked the question, who is checking the X-ray time after surgery? Here is only like a 10% from the audience. Кто надевает полностью как бы все снаряжения как бы от рентгена? Я имею в виду там шею, там все. А кто вообще оперирует этот эндурологию, там перкутанной хирургии, кто занимается? Now we can see the result. So among the audience, like 10 to 15% of our colleagues, they uses these principles. But suddenly, most of us not looking for our health, and then they're not controlling the X-ray usage.
It's surprising considering how many people over here in the audience do at least 200. It doesn't matter whether it's PCNL or RIRS or whatever, 200 cases per year of endourology. Okay, slowly we're getting more and more hands coming up. All of us who are doing 200 cases have a 10% risk of developing thyroid cancer in 10 years. That's how much it is. And Saeed said he's here. So if you are as old as me, I'm already at the threshold where I may have if I had not taken care, but you are starting. So 10 years from now, you have a 10% chance. That means in this audience, about 100 people, 10 of these 100 people will have thyroid cancer because of radiation if they don't take care. That's a lot.
And one thing more that I have seen some colleagues, they do flexible ureteroscopy with the X-ray. When they start their training, they put the pedal down and they do X-ray to see the calyceal system. You don't need that. And the PCNL have seen people doing 25 minutes. 25 minutes to do the puncture, and you have seen this. 25 minutes is huge. I think flexible ureteroscopy should be between 30 seconds to 1 minute maximum. The PCNL, if you do ultrasound, you don't need it, but maybe for the dilatation, for the guide wire, should be not more than 2-3 minutes. 20 minutes is too much for everyone, patients, other people, anesthetists, and the people around you.
You know, when we ask for data for studies, it is almost impossible to get radiation time and radiation dose because not many people record it. But we were doing some studies from the available data that we had. 3 interesting things which I found. Number one,
it's all consultants, these are not junior people, at least they are not supposed to be junior. Radiation time and the radiation dose have no correlation because people are spending maybe 10 seconds or 20 seconds, but they are using 25 frames per second. They are keeping the C-arm too close to the patient. They have too many exposures. So it also matters the amount of radiation that you expose the patient, not only the time, which is why it becomes important to do a radiation course. So you wear all the gowns, and all of us are wearing gowns, but not many of us keep the radiation tag inside. We don't keep the radiation tag to measure how much of radiation is happening. If you go to an X-ray department, even not everybody is wearing a fluoroscopy gown over there. They don't wear X-ray gown, they're working in the X-ray department because the X-ray department is lead-lined, it is protected. But they will all carry a radiation tag because scatter radiation, what we think as radiation which is not going to affect us, it travels quite far and you are likely to get exposed to that. So you may come into the operation theater, you may think, oh, I'm standing far away, you can still have radiation exposure.
Yeah. Шот Усунч, у вас есть комментарии?
Я согласен с мнением наших коллег. Вот мы говорим о враче, мы говорим о пациенте, но мы не должны забывать, что рядом с нами еще есть медсестры, санитарки, анестезиологи, анестезистки. То есть в любом случае надо беречь себя. И я понимаю, вот я сейчас посмотрел в зал, кто пользуется рентгеновскими защитными. Наши, когда мы говорим, мы понимаем только фарбу. Ну, кто-то еще, вот сейчас я уже вижу, да, вот для защиты щитовидной железы. Ну, и специальные очки, и специальные перчатки. Я немножко сомневаюсь, что у нас в Узбекистане в большинстве клиник используют специальные перчатки, которые защищают от рентгена. Поэтому лучше всего максимально предостеречься и уменьшить время использования радиации. Это мое мнение.
Спасибо. Принципы Алара, значит, это как бы наш помощник, должно быть как бы ассистентом каждого эндоуролога, который заходит в операционную, будет работать под рентгеном. Также как бы на нас, как бы у главного хирурга, лежит ответственность на всю команду. То есть рядом с нами стоят еще медсестры, там, санитарки, анестезиологи, наши ассистенты и еще пациенты. Поэтому зачастую мы часто наблюдаем, вот как Vineet Gauhar упомянул, что мы не смотрим за временем и за дозой рентгеновского облучения, которое мы используем. Принципы Алара, они вот придуманы для того, чтобы нас предупредить и какими методами как бы максимально снизить дозу облучения во время операции. Это дистанция как бы рук хирурга от поля зрения рентгена, как бы краткое нажатие рентгена, как бы абсолютно не рекомендуется как бы долго держать. Многие из нас как бы сами в это время фокусируются на камне или на пациента, мы долго держим, иногда забываем, что наша нога находится на педали уже долго, там минуты, там 30 секунд. Это очень ужасная доза рентгена, которая может привести к очень как бы плохим осложнениям и как бы всяким онкологическим заболеваниям. Поэтому давайте, коллеги, мы не забудем забывать в первую очередь про себя, про хирургов, про коллег, потом и про пациента тоже, и об этом будем предупреждать наших молодых коллег и всех коллег. So I would like to thank you for your nice conversation. Thank you. So our last part of this section is the state-of-the-art lecture from the renowned Nariman Gadzhiev, Tips and Tricks of Flexible Ureteroscopy.
Добрый день, салам алейкум, дорогие друзья. С любовью из Санкт-Петербурга. Можно поставить мою презентацию? Итак, у нас 20 минут. Я буду говорить на русском. Уверен, что наши англоязычные коллеги много это знают, и мне кажется, все будет более-менее понятно. У меня нет никакого конфликта интересов. Я стараюсь делиться какими-то интересными нюансами в своем телеграм-канале. У нас существует уроклуб для русскоязычных урологов. Ну и всех призываю делиться вот в Твиттере, он нынче называется Иксом. Очень такое тесное комьюнити, где можно делиться какими-то идеями, получить консилиум, мнение коллег из-за рубежа. Поэтому очень, на мой взгляд, достаточно крутая опция. И у меня большая просьба не убирать далеко телефон, и мы будем вместе с вами идти через эту презентацию. Итак, первое, сегодня говорили о размерности камня. Это действительно то, что на сегодняшний день является такой злободневной темой. У нас все показания сейчас крутятся вокруг 2 сантиметров. Ну, до 2 мы делаем гибкую хирургию, после 2 мы можем предлагать перкутанные варианты. Но при этом надо понимать, что эффективность традиционной гибкой хирургии, она на уровне 70%. Представляете, дорогие гибкие эндоскопы, стенты, наркоз. И все это ради чего? Ну вот если оценивать эффективность по строгим критериям, по данным компьютерной томографии, то результаты не очень утешительные. А теперь посмотрите на эти диаметры. Да? У нас 2-сантиметровый камень 2 на 5 на 5, это 262 кубических миллиметра, и 12 на 12 на 12. У нас уже совершенно другой объем. И теперь посмотрите, равнозначны ли они. Да, и мы знаем о том, что у пациентов с увеличением объема камня на 1000 кубических миллиметров у нас эффективность падает почти в 2–2,5 раза. Поэтому, к сожалению, несмотря на то, что рекомендовано измерять размеры, именно объем определяет эффективность вашего вмешательства. Как можно определять объем? Есть формула эллипсоида, я думаю, все ее знают. Значит, есть аппаратное определение камней. И в своей практике мы используем обычный просмотрщик, это у нас Инобитек, наша отечественная воронежская разработка. Значит, методом увеличения зоны роста мы можем запросто, самостоятельно, вне зависимости от сложности стереолитометрической конфигурации камня, определить его объем. Очень просто. Пожалуйста, вот этот камень 1300 кубических миллиметров. И мы понимаем, что операция будет долгой. Скорее всего, я буду использовать здесь гибкую хирургию с применением аспирационных кожухов. Нам еще предстоит увидеть результаты многоцентровых исследований, которые будут опираться уже не на размер, а на объем камня. У меня большая просьба провести небольшое голосование. Сфотографируйте, пожалуйста, QR-код, перейдите и проголосуйте. А мы потом в течение дня, либо сегодня, либо завтра, представим результаты. Огромное количество практикующих коллег. Давайте использовать эту возможность. Да? Итак, что вы используете для оценки размерности камня? Едем дальше. Выбор анестезии. Достаточно серьезная история. Значит, я уверен, что в практике, вот если у кого-то было, можете поднять руку, но тем не менее нет-нет, да и да, бывают пациенты, которым в целом анестезия противопоказана. И мы можем оперировать пациентов без наркоза. Женщина, здесь нет аудио, но мы с ней переговариваемся, мы разговариваем, как ей больно, не больно, все ли хорошо, ну, по анестезиологическим противопоказаниям. Общая анестезия, значит, это может быть без апноэ. Сегодня во время живой хирургии вот наш анестезиолог очень здорово помогал, значит, потому что стрелять по движущейся мишени, особенно если вы планируете дастинг, то есть распыление, гораздо удобнее, если камешек стоит на месте и не движется. И в этом смысле апноэ, не знаю, запустится видео, так, давайте еще разок. Значит, да, вот пошло. Средняя картинка – это апноэ, там, где пациент не дышит, есть определенная последовательность, это оксигенация чистым кислородом, и мы оцениваем по сатурации кислорода. Если она падает, мы, собственно, даем паузу, реоксигенируем пациента, ревентиляция, и потом обратно возвращаем его в апноэ. Есть вариант использования высокочастотной вентиляции. Что у нас вот с пациенткой, пусть немного запоздал. Значит, говоря об спинальной анестезии.
Да, вы помните, что у нас всегда есть
Говоря о спинальной анестезии, да, абсолютно приемлемый вариант. Дешево, практично, но если вы заботитесь о своем койко-дне, у нас он 2,5–3 койко-дня, то надо понимать, что постпункционный болевой синдром иногда может оставить пациента на койке до 10–12 дней с серьезными, сильными головными болями. Поэтому этот момент, на мой взгляд, не стоит недооценивать. Поэтому общая анестезия, на мой взгляд, является оптимальным вариантом. Пожалуйста, еще раз сфотографируем. Маленькое голосование. Будет интересно посмотреть, как проходит распределение выбора по методам анестезии. Движемся дальше. Положение тела во время гибкой хирургии. Сегодня, вот если заметили, мы переводили пациента в определенное положение. У нас принципиально есть работы, которые говорят о том, что Trendelenburg позиция или T-tilt position или T-trend position или kidney fixed position, когда мы укладываем пациента в тренд при использовании либо без кожуха, либо с традиционным кожухом, улучшает stone free rate. Это связано с тем, что фрагменты, которые образуются, они, собственно, остаются наверху, они не уходят вниз, и вы их не пропускаете случайно. Но в случаях с применением фанс кожухов, аспирационных кожухов, помогает обратно. Это обратный Тренделенбург, это не Фоулер, но тем не менее. Значит, когда мы снижаем гравитационные усилия, и фрагменты очень хорошо вместе с аспирацией идут прямо на кончик инструмента. И в этом смысле про положение тела тоже лучше не стоит забывать. Давайте еще одна фотография, посмотрим, кто из вас использует какое положение. Угу, движемся. Осмотр мочеточника в начале операции. Бывает такое, что идешь на камень в почке, сразу берешь гибкий инструмент, который стоит не очень дешево, а мочеточник встречается, вернее, камень встречается в мочеточнике. Очень неприятный сюрприз, потому что этот камень запросто можно было бы убрать полуригидным инструментом. И да, действительно, есть так называемая фрайбургская методика, которая предполагает изначальную инспекцию мочеточника, для того, чтобы предотвратить неожиданную встречу с камнем в мочеточнике, либо посмотреть, нет ли там каких структур, сужений, каких-то патологических образований. Значит, в нашей клинике сейчас проводится исследование, вот Александр Денисович должен быть где-то в зале, где мы перед началом операции выполняем ультразвуковое исследование на столе, и в случае, если это солитарный камень почки, и мы видим во время индукции, что он там, то нет смысла брать полуригидный инструмент, и мы запросто, как вот сегодня вы могли видеть, мы заходим в пузырь и спокойно, свободной рукой входим в устье и делаем все, что нужно. Если, скажем, вам нужен будет проводник, и вот с 63 до 5% снижается вероятность встречи с камнем в мочеточнике, что, на мой взгляд, достаточно серьезное преимущество. Небольшой опрос, пожалуйста. Осматриваете ли вы мочеточник в начале операции полуригидным инструментом? Движемся дальше. Итак, ирригация и давление в почке. На сегодняшний день у нас есть принципиально 4 варианта. Пятый я не стал показывать, вы его увидите, когда будете отвечать на вопрос. Это гравитационная ирригация, это усиленная гравитация при помощи pressure bag, это ручная помпа, значит, и это машинная ирригация. Так. И машинная ирригация. Значит, по большому счету, да, и давайте сразу, какой вариант ирригации вы используете? По большому счету нужно помнить, что у нас безопасный лимит давления 30 сантиметров. Надо понимать, что рефлюкс начинается до 10 миллиметров норма, рефлюкс начинается с 30-40. И надо понимать, что пик давления с применением ирригационных систем, когда мы форсированно жмем на помпу, мы можем поднять до 500 сантиметров. Как мы можем оценивать эффективность ирригации? Да, вот на этом видео видно, что у нас нет притока, у нас не очень адекватный отток. На видео внизу мы видим, как из кожуха активно истекает жидкость. Это косвенный признак того, что у нас эффективный отток, эффективная ирригация. Есть варианты, когда мы используем специальные скопы, оснащенные специальным датчиком для измерения давления. Можно использовать комбитранс через анестезиологическая система для оценки давления центрального венозного. Можно подключать через 5-френчевый катетер, что в принципе достаточно удобно в определенных ситуациях. Я уже не говорю про iWire, который используют наши рентгеноинтервенционные специалисты. Значит, что можно использовать? Да, кожух традиционный мы сказали, аспирационный кожух. И есть следующий вариант, это когда мы используем 7,5 френч и ставим 5-френчевый катетер. При этом работа во время дробления осуществляется очень-очень удобно, очень чисто. То есть вот как это происходит. То есть тогда, когда, скажем, нет возможности поставить кожух, можно поставить вот такой дополнительный порт, и при этом площадь поперечного сечения она будет меньше, чем у кожуха 12-14 френч. В исследовании, которое мы провели и сейчас находится вот под рассмотрением, самый эффективный вариант – это когда мы используем гибкий аспирационный кожух и одновременную аспирацию. При этом давление у нас редко поднимается выше 5 сантиметров. У нас кликер не очень работает. Посмотрите, fence with AI with suction. Поэтому я думаю, что вот за этим как раз-таки в плане безопасного давления в почке и есть будущее. Говоря о фенсах, у нас есть на сегодняшний день уже традиционный вариант, но при этом надо понимать, что когда мы работаем в нижней чашечке, вот это был звук, когда рвутся рычаги. То есть, когда вы пытаетесь активно завести этот кожух аспирационный в нижнюю чашечку, ну, вот может случиться потеря инструмента. Вот эти умелые руки, это вот Vineet мне отправлял это фото. Вот если очень-очень постараться, можно загнать и в нижнюю группу чашечек. И сегодня, кстати, у нас получилось. Ну и новые аспирационные кожухи, которые имеют рычажок, который позволяет избежать избыточного давления на рычаг эндоскопа. Поэтому я думаю, что в скором времени они придут на смену существующим. Ну вот в Твиттере наш коллега Чуйкалун поделился, умелые ручки, можно сделать этот аспирационный кожух самому, проявить немножко смекалки. Говоря о том, как именно эффективно осуществлять аспирацию с использованием фенс-кожухов, то есть это перманентная ирригация.
In order to increase the effectiveness of your fence, you just have to elevate the tip of your scope while removing fragments through the sheath. Otherwise, you will push the fragments back with the irrigation flow coming out from the flexible. And meanwhile, you have to continue delicate pumping so to keep the backflow at the permanent level, which with the aspiration will do the best.
Ну вот примерно этим мы сегодня утром и занимались. Надеюсь, понятно, потому что не все это бывает описано в книжках, что-то вот из персонального такого опыта. Но в общем и целом система абсолютно работает. Для тех, кто только-только начинает знакомиться с аспирационными кожухами, прошу сфотографировать этот QR-код, где подробно изложена инструкция по применению и использованию этих аспирационных кожухов. Видео находится в свободном доступе, поэтому проблемы не будет. Итак, и говоря об эффективности, и вот мы сегодня с Дильмуродом договорились, что завтра пациентки выполнят компьютерную томографию. Дело в том, что с использованием гибких аспирационных кожухов у нас уже появляется возможность оценки так называемого immediate stone free, когда мы не ждем месяц, 3 месяца после операции, а выполняем КТ на первые сутки для того, чтобы понять, ну, какова истинная эффективность выполненной нами операции. И фансы позволяют достигать ее практически в 95%. Это достаточно высокий процент. Новшество тулей-волоконных лазеров. Вот сегодня не получилось показать tissue сенсор, покажу его здесь на слайде, потому что он требует незначительной калибровки. И вот обратите внимание, как обычный лазер себя ведет. То есть мы запросто можем попасть мимо камня, при этом повредить слизистую. Такое бывает особенно у начинающих хирургов. И теперь посмотрите, как работает tissue сенсор во включенном режиме. Все, ткани в безопасности. Вот, на мой взгляд, это очень серьезное продвижение вот в изучении лазерных технологий, которое, на мой взгляд, опять-таки должно быть практически в каждой лазерной системе. Обратите внимание на новые фрагментационные способности тулей-волоконных лазеров, о которых еще Алексей Георгиевич подробнее расскажет, покажет. Можно работать с настройками в 30 джоулей 1 Гц. И посмотрите, какие фрагментационные способности сейчас показывает тулей-волоконный лазер. Опять-таки у меня нет конфликта интересов. В исследовании, которое провел Мартов, эффективность, термическая безопасность в отношении тканей, она абсолютно сопоставима с таковыми при стандартных режимах. То есть этот режим ничем не хуже, ничем не опаснее тех, что используются вот в стандартном режиме. Исследования по оценке температурной безопасности показала, что с применением вот AFP пакета, то есть Advanced Fragmentation Pulse, мы видим, что температурные режимы, они сопоставимы. Посмотрите, у меня не работает лазерная указка. То есть вот наш AFP режим, и это режим стандартный U3. Мы можем смотреть вот гольмиевый режим. Они, в принципе, все находятся в безопасной зоне по термической безопасности. Самое главное – это адекватная ирригация. Нет ирригации, температура взлетает с любым лазером. Поэтому запомните, если у вас плохая ирригация и вы собираетесь дробить камень, обязательно остановитесь, наладьте, чтобы у вас был приток-отток. Говоря о Direct In-Scope Suction, и вот этим термином мы также благодарны Виниту Гauharу. Значит, так вот, это аспирация через рабочий канал, которая долгое время считалась, ну, вот нельзя аспирировать, риск кровотечения нет, можно, нужно, естественно, все это нужно делать разумно. И для того, чтобы осуществлять эффективную аспирацию, нужно работать в режиме работы лазера в пыль. И здесь у нас есть два варианта. Либо это специальные дополнительные линии, мы закрываем приток, налаживаем аспирацию. У нас очень, Азим, плохо работает кликер.
In order to achieve complete stone clearance, we utilize direct in-scope suction with a second line. After producing enough fine dust, we have to just aspirate with the syringe and close the irrigation
с кнопкой аспирационной. Вот как на втором видео, здесь мы используем и гибкий аспирационный кожух, и инструменты со встроенной аспирацией, так называемый double dis, то есть двойная аспирация. Но по опыту скажу, что может быть это небольшой перебор, потому что достаточно одного из двух. Поэтому, но тем не менее. Ну, нельзя не сказать про CVAC, это так называемый новый ДИС. Раньше он использовался как третий вариант аспирации. Сейчас эти эндоскопы оснащены камерой. Если можно пропустить немножко вперед это видео, вот техникам вопрос примерно с половиной. Сейчас идет дробление, потом будет аспирация. Но проблема с этими инструментами в том, что с одновременной усиленной аспирацией усиливается ирригация. И если у вас по какой-то причине рабочий канал, аспирационный канал забился камнями, но при этом аспирация у вас продолжает бить ключом, и это может создать очень серьезные предпосылки для осложнений. Поэтому с этими инструментами, естественно, нужно работать после предварительной прохождения подготовки, которую предоставляет компания. Ну, просто чтобы вы знали, что есть и вот CVAC-система, по сути, это такой же, значит, вариант in-scope suction, то есть или аспирации через рабочий канал. Ну, иногда бывает застревают камни в корзинке, и нужно помнить, что в 3,6 рабочий канал спокойно проходит лазерное волокно до 200 микрон и корзинка до 2 френчей. Поэтому запросто можно зайти лазерным волокном, разбить камень, при этом не отстригая корзинку, это тоже очень здорово помогает. Говоря о том, чем заканчивать операцию, обязательно. Я напоминаю всем, что есть специальные рекомендации по каждой операции Международного альянса, и вот с Саидом Бен Амри мы вместе входим, и Винитом Гauharом входим в комитет, обязательно осматриваем полость мочеточника в конце операции, и именно здесь мы определяем, насколько мы будем ставить стенд, потому что иногда возможны проблемы. Да, обратите внимание, все, вроде бы операция прошла хорошо, идем назад, упс, у нас вот такой, так называемый лонгитудинальные повреждения высокой степени кожухом, но при этом, посмотрите, вот Саид Бен Амри любезно делился результатами, эти продольные разрывы, они очень, к счастью, они очень здорово заживают, и через 4 недели в целом от них не остается и следа. Исследования, которые провели Манош Монга с участием Оливье Траксера, показывают, что частота структурообразования после вот таких вот повреждений 1,8. Просто чтобы вы помнили о том, что даже после неосложненной уретероскопии риск развития структуры 2-3%. То есть получается, что у нас плюс-минус мы не приводим к увеличению риска развития структур. Означает ли это, что можно вести себя в мочеточнике как хочется? Конечно, нет. Мочеточник очень обидчивый орган. Еще один вопрос напоследок. Осматриваете ли вы в конце операции мочеточник? Угу. Ну и вот напоследок, смешанная реальность, это то, что вот это наши проекты. с применением хлои для каких-то сложных множественных камней, когда приходится искать их. И вот можно использовать это как референсную модель. Это вот мужественная спина Дмитрия Сергеевича Горелова. Вот он сегодня помогал мне в операционной. Значит, а вот справа, это недавно опубликовал Фабио, наш друг, который использует смешанную реальность как замену физическим стойкам. Представляете, вы одели очки, зашли, и все стойки у вас перед глазами, то есть у вас операционная свободная. Нет вот этого сонма кабелей, это паста на полу и так далее. Значит, ну и говоря про роботическую историю, при всем уважении, я вот попробовал все существующие варианты. Сейчас, к сожалению, роботическая история, она больше напоминает работу с манипуляторами. Ну вот представьте себе вот это дробление джойстиком, при всем уважении к создателям Или, но вот если вы пробовали, ощущение, что ты сильно не успеваешь. Ну как бы она и так гибкая хирургия, не супер драйвовая, но вот с этим делом просто можно заснуть, постареть. В общем, пока мы не там. А теперь посмотрите на tissue sensor, который женат на искусственном интеллекте. Посмотрите, что он делает. Этим видео поделился Оливье вот недавно в Твиттере. Мы же все смотрим, все наблюдаем. Это, кстати, еще один повод быть там. И вот посмотрите, что лазер сам выполняет с камнем. На мой взгляд, вот мы движемся в сторону, когда вкупе с искусственным интеллектом, с хорошей математической моделью движений, этот лазер действительно встанет на службу эндоурологов, которые ничуть не хуже онкоурологов, у которых уже есть свой робот и очень неплохой. Поэтому будем надеяться, что мы доживем в скором времени до этих чудес. У меня все, и вот небольшое заключение. Вот, вам нужно знать, что вы делаете в каждую минуту. У вас в голове должен быть план А, план Б, план С. Остерегайтесь мочеточника, очень обидчивый. Любое сопротивление, старайтесь брать инструмент поменьше. Если вы не предстентировали, поставьте стенд, вернитесь обратно. Не бойтесь этапности. Готовьте свой мочеточник. Это альфа-блокаторы. Это, кстати, у нас этот слайд, видимо, мы перешагнули. Альфа-блокаторы, предстентирование – это абсолютно рабочие варианты. Старайтесь держать давление в почке на минимуме. Это ключ к безопасной хирургии. Ну и в конце обязательно осматривайте мочеточник, потому что не хотелось бы, вот вроде бы пришел пациент на удаление камня почки, однодневная хирургия, утром пришел, вечером ушел, а потом через месяц у пациента структура и надо планировать на реконструкцию. Не самое желаемое последствие. Ну, у меня все. Спасибо огромное. Узбекистан лучший. Есть ли вопросы?
Если вопросы есть, пожалуйста, из зала.
А я постараюсь сегодня или завтра подготовить маленькое сообщение по распределению по наших ответов. Ладно, будет действительно интересно. Спасибо.
Спасибо большое. Значит, у нас на 30 минут, значит, время, час, время для обеда. Значит, наша следующая сессия начнется ровно в 1:30. Очень интересная следующая сессия. Спасибо огромное всем.
Welcome to an exciting journey through the history and future of medicine. From the very beginning of our existence, humans fought for survival. In prehistoric times, people sought shelter in caves, tried to ignite fire, and treated wounds with primitive methods. Ancient Egyptians created the first surgical instruments and mastered embalming. In China, traditional medicine emerged using